Starting. All right. Assalamu alaikum, everyone. My name is Samhar Alouch. I'm a fifth-year medical student, and today, inshallah, we will go through the renal OSPE review. This is my email and this is my phone number. Please feel free to reach out at any time before your exam if you have any question. Okay. So this is the table of content. First, we will go through pathology. So we will go through like nephrotic syndrome, cystic diseases, tumors, and inflammations. And then we will go through radiology or microbiology. Depends on which one you guys prefer. Microbiology is easier, so I think we will go through pathology, then microbiology, then radiology. Okay, so just to explain how things will go, I'll explain the pictures for the OSPE exam, but I also included some stuff that are important because they don't just give you a picture and ask what is this. They give you sometimes a scenario, so you need to know the disease. And I assume like it's one day before the exam, so I assume you guys reviewed everything and you know at this point what each disease had like as symptoms, treatments, diagnosis. So I just included them like this. Just a sec, yeah, like this. So each time you have a slide, there is pictures here and behind, and we will explain the pictures and like this disease have this and this disease have that. And then we have this note that appears that have the summary of everything we've discussed and some extra stuff about the disease itself. You can use it as a review for your own study. It's not highly important for OSPE itself, but it's important for like your OSCE, for your MCQ and the SAQ. So without any further ado, let's start. So first we'll start with the pathology. So here we have the normal kidney. Okay, here we have the normal kidney. So the blood reach here through the artery, and then it goes to the glomerula, and then it comes back through the renal vein. Why does that happen? So the blood, when it passes through the glomerula, it gets filtered, and the bad things in the blood go to the Pullman capsule and go through these tubules, and then through the ureter, and then it goes through the urine. So here the blood reach, this is the afferent arteriole. So here is the renal artery, I would say. And it reach here, the afferent arteriole. Blood go through the glomerulus. The blood got filtered. And like the bad thing in the blood got filtered. Some plasma, some sodium, chloride, calcium, some stuff get filtered. And then the blood goes through here. The bad things go through the Pullman capsule. So when the blood moves through the capillary and it needs to reach the Bowman capsule, which is here, it passes through three layers. First is the endothelium, which is the red part. Then we have the basement membrane, and then we have the epithelium or the podocytes. So it's the blood vessel have three layers. So first it will pass through the endothelium, which is the first layer, then the basement membrane. Then at the end, like out of the basement membrane, there is the food processes, these things, which is the podocytes. It needs to pass through all of these to reach the Bowman capsule, which has its own epithelium. The epithelium here, the one for the blood vessels, the podocytes, is called the visceral epithelium. The one at the Bowman capsule, it's called parietal epithelium. Okay, so blood need to pass through these three layers to like the thing that get filtered, pass through these layers and reach the Bowman capsule. So what does pass and what doesn't? I think you guys know this information by now, but I will just go through them immediately. So the capillary have some pores that allow things to pass. Then the basement membrane and podocytes have some charge. So let's say it's negatively charged, so it repels some other stuff. So the basement membrane and the podocytes are important for preventing protein from being filtered. So we will filter some stuff like glucose, sodium, and stuff, but protein should not be filtered. And it's prevented from being filtered through the basement membrane and the podocytes. Also, blood should not be filtered, like the RBCs itself, and that's happened by the capillaries. Okay, so if I damage the capillaries, what will be filtered? The RBCs, some protein with it, but the RBCs are the main thing that's going to be filtered. If I damage the basement membrane and the podocytes, what will be filtered? The protein. Because basement membrane and podocytes repel protein. It doesn't allow it to be filtered. If we damage them, it's going to be filtered. So again, this is the normal kidney in like histology. As you can see here, this is the endothelium. Then there is the basement membrane. And at the end of the basement membrane, there is the podocyte. And on the other side, there is the parietal epithelium. And this white area is the Bowman capsule. On electron microscopy, this is the endothelium, the one that has pores between it, yani the layer itself, then the basement membrane, the thick layer, and then here the foot processes, which is the epithelium or podocytes. And here on the other side is the parietal epithelium. If I damage the endothelium, I will have RBCs in the urine. If I damage the basement membrane or the podocytes, I will have protein there. Okay, now one more thing. There is a structure here, like in between the glomeruli. So you see here, these like in between, it's called mesangium. And mesangium is also, if it's damaged, it will allow RBCs to be filtered out. So two things will allow RBCs to be filtered out, endothelium and mesangium. And two things will allow protein to be out, which is damaging the basement membrane and the podocyte. Okay, and now last picture, there's basement membrane, there's the capillary lumen, which is endothelium, and here we have the foot processes, same thing here. خلاص, I think now the picture is clear. So now let's start with nephritic and nephrotic syndrome. Nephritic syndrome, it has itic, so it's like nephritis, it's like an inflammation, and it's inflammation to the two layers, which is either mesangium or the endothelium. Okay, so nephritic is damage to the mesangium or endothelium. If we damage mesangium and endothelium, what we will have? We'll have RBCs in the urine, which is hematuria. So the most important thing about nephritic syndrome is having hematuria. Okay, so we'll have RBCs in the blood, in the urine. And there will be some proteinuria, of course, but it's not that high. It doesn't reach the cutoff, which is 3.5. 3.5 is like having severe proteinuria. So nephritic syndrome has proteinuria, but it's not that highly like damaging or stuff. No, it's not that important. The most important thing about nephritic is the hematuria. Once you have damage to these mesangium and endothelium, you will have damage to the filtration barrier. We will have proteinuria, of course, and we will have edema because of that. But the important one is having dysmorphic RBCs and RBCs casts in the urine, which is hematuria. There will be also damage to the kidney, so we will have high BUN and creatinine ratio, oliguria, and stuff. Now, nephrotic syndrome, it has otic, so it's not an inflammation. It's otic, not etic. Okay, so since it's not an inflammation, it's damage to the basement membrane or podocytes. And what we say, if we damage these, we will have proteinuria. So it will have severe proteinuria, which is higher than 3.5. Okay, once we have damage to the proteinuria, mainly the albumin will be decreased, and then we will have other things because of the protein deficiency. So we will have decreased immunoglobulins because protein is important to make them. So we'll have infection. We'll have proteinuria and frothy urine because the protein in the urine will make it frothy, and we'll have like frothy urine. We will have decreased in antithrombin 3 because also it makes from protein. So we'll have thrombosis. We will have hyperlipidemia, edema, fatty casts, and stuff. You need to memorize these things. These are not important for OSPE that much, but I just wanted to review them before we start. The important thing here is if we damage the podocytes or the basement membrane, we will have protein loss, which is nephrotic. If we damage the endothelium and mesangial layer, we will have red blood cells, which is nephritic. So I just want you to differentiate. Nephrotic is damage to podocytes or basement membrane, we will have protein. Nephritic is inflammation or damage of the endothelium and mesangial layer, which will have blood in it. Okay? So now let's start with nephritic syndromes. As we said, nephritic is damage to RBC, to basement membrane, and not basement. Nephritic is inflammation, damage to mesangium or endothelium, and we will have RBCs in the urine. We will have several diseases, and most of them are related to immune complex deposition. So we'll have an immune cells and immune globulins that are depositing on the mesangium and the endothelium and causing inflammation and damage to it. The first one is PSGN, post-streptococcal glomerulonephritis. This is a disease that happened after someone suffer from what's called Streptococcus pyogenes infection. It happens 2 weeks after that. So someone present to you with sore throat, fever and stuff, and after 2 weeks, like after he resolves from the infection and everything, he developed nephritic syndrome, which is hematuria and proteinuria. This guy is having PSGN. So the scenario will be like this: someone have sore throats and fever, and after 2 weeks he have hematuria. That's definitely nephritic because it's hematuria. And since it's after 2 weeks from an infection, that's definitely PSGN. Okay? It's because of immune complex deposition. Where does it, like these immune complex go? It goes between the basement membrane and the epithelium. So it's subepithelial. Sub is mean under, and epithelial is the epithelium. So it's between the basement membrane and the epithelium. So it's subepithelial. You can see the picture here. This is the basement membrane, this is the podocytes, and here is the immune complex deposition. And since it's subepithelial, the mnemonic for this is epithelial. The B is with the B. So we have PSGN, subepithelial, because there are other diseases that are subendothelial, which is under the endothelium, and these diseases start with a D. So since PSGN start with a B, then it's subepithelial, okay? Okay, so the light microscopy for PSGN is hypercellularity of the mesangium, because there is like immune complex and then inflammation, neutrophils are coming in and out, so it's hypercellular. So the light microscopy of PSGN is hypercellular. The immune fluorescence is granular. We call it lumpy-pumpy. Why it's granular? It doesn't damage a specific area. It's just immune complex deposition. So here there is an immune complex, but here there is not. And here there is not. And here maybe there is. So it's somewhere in, somewhere out, somewhere in, somewhere out. So as you can see here, it's just you see, yani it's like dots, not one line. It's just dots. So here there is nothing, and then here there is, and here there is nothing. So that's what we call granular, okay? Or lumpy pumpy. Okay, so for the last time, PSGN, someone with sore throats, fever, and after 2 weeks, he developed hematuria. That's nephritic because there is hematuria, and since it's after 2 weeks, that's PSGN. Why? Because immune complex deposition. On light microscopy, there is hypercellularity. On the immune fluorescence, there is granular because it's immune complex deposition, not like attacking specific things. Somewhere in, somewhere out, and that's granular. And in electron microscopy, it's subepithelial because PSGN starts with a P and subepithelial has B. Subepithelial humps. Okay. The treatment, they like there is spontaneous resolution. يعني ما في داعي تعملوا لهم treatment, just symptomatic treatment. Now let's go to the second disease. It's IgA nephropathy, which is called also Berger disease. Please know this name because they use it more than IgA nephropathy. So Berger disease or IgA nephropathy. It is also a nephritic syndrome. So the patient will present with hematuria. Okay, and it's not due to immune complex deposition because immune complex mean many things. No, this one is selective. It's just IgA deposition. So Berger disease or IgA nephropathy is also a nephritic syndrome that causes hematuria and proteinuria, but it's due to IgA deposition, not immune complex deposition, and that's why it's called IgA nephropathy. Now, what's the difference? IgA nephropathy presents after a few days after an infection. So someone had sore throats and fever and runny nose or whatever, and after 2 or 3 days, till like a week or 10 days, it's less than 2 weeks, okay? Less than 2 weeks presented with hematuria, that's definitely IgA nephropathy. So more than 2 weeks, PSGN. Less than 2 weeks, it's IgA nephropathy. They will present with hematuria and proteinuria and everything of nephritic syndrome. Now for the light microscopy, we have mesangial cells proliferation. It's not hypercellularity. It's not like neutrophils and many immune cells is there because there was immune complex deposition. Many things are depositioning. Here it's just IgA, so it's not like hypercellularity, but because these depositions happen at the mesangium, we will have mesangial proliferation. So we'll see this pink color everywhere. Okay, so IgA nephropathy, the immune complex, not immune complex, the IgA will deposit in the mesangium, causing mesangial proliferation and matrix expansion, and it would cause this presentation of like many pink stuff in the glomerulus itself. And we said in the glomerulus itself, it's the mesangium. So if you saw mesangium expansion and pinking, that would be IgA nephropathy. In the immune fluorescence, it will be granular also because it's immune deposition, but it's only IgA, so it will be granular like here. And finally, it may cause something called HSP, which is like having it's a very long disease, big disease, but the main thing about it is that they have burbera on their skin. Okay, I have a mnemonic for it. That's not my field because it's just OSPE review, but it's FAG-N, and each letter represents something. So B is for burbera, H is for hematuria, A is for like abdominal pain, I is for interception because it may lead to interception, and N is like nephretic syndrome. So that's not my domain. It doesn't matter. If the thing that matter here, that if you saw someone with Barbara, that's HSP, that's IgA nephropathy. That's all I want you to know from this slide. This you want to know, you don't want to know, it's fine. Now, we covered two diseases, PSGN and IgA nephropathy. These two causes nephretic syndrome. Now, the third one that causes nephretic syndrome is SLE, systemic lupus erythematosus. Now, I expect you to know the symptoms of SLE, like the malar rash, the brain soap mnemonic thingy. يعني I expect you to know these, but let's cover the renal stuff. So SLE causes five diseases. The one that matters are these two, type 4 and type 5. So SLE causes type 4 disease and type 5 disease. Type 4 is nephretic. Type 5 is nephrotic. We don't want to discuss the nephrotic now. Let's focus on the nephretic one. SLE causes something called diffuse proliferative glomerulonephritis. This one, okay? So if someone has SLE and suddenly developed hematuria, then it's most likely diffuse proliferative glomerulonephritis. From the name, it's called diffuse proliferative. So what layers do you think that are proliferating? All of them, okay? Because it diffuse proliferative. So the membrane, the endothelium, the mesangium, everything is proliferating. So SLE causes diffuse proliferative glomerulonephritis. Everything is proliferating and it's diffuse. It's not like one area. No, it's through the whole glomerulus and it's through most of the layer, mesangium, endothelium, even membrane, everything, okay? But mainly mesangium and endothelium because it's a nephretic syndrome. Of course, it will cause hematuria and proteinuria. It will have SLE presentations like the brain soap thingy, but mainly يعني malar rash. It's the main thing. Now let's talk about on microscopy. Since there is diffuse proliferation of everything, it will look like a loop, wire loop. So here you will have this wire loop presentation. So SLE, diffuse proliferative, and it will lead to wire loop lesions. Okay. On immune fluorescence, it's also granular because it's due to also immune stuff depositioning in the glomerulus. So it will also appear granular. However, where does this immune complex depositioning? It's subendothelial. So we have the here epithelium, basement membrane, and here the endothelium, and here we have subendothelial stuff. And see, the disease called diffuse proliferative. It starts with a D and it's subendothelial. DBGN, subendothelial. So SLE, patient will have like SLE presentation, malar rash and stuff. They will have hematuria, proteinuria due to proliferation of mesangium and endothelium. So it's diffuse proliferation. On light microscopy, we'll have wire looping because everything is perforated. It will be granular because it's also immune complex depositioning, and it's subendothelial because it starts with a D, diffuse, so subendothelial. All right. And these are like SLE presentations, a discoid lesion or malar rash. I put them because in the question they may mention them like, oh, patient presented with a discoid lesion or a malar rash. You know, it's SLE from that. Okay. So we finished the three nephretic syndromes. Now the fourth one, Alport syndrome. Alport syndrome is like type 4 collagen deficiency. As we know, we said the glomerular barrier, it's made of endothelium, and then there is basement membrane, and in the basement membrane there is the podocyte. Alport syndrome is type 4 collagen deficiency, so it's impair the collagen development in your body. So the basement membrane will be damaged, the endothelium will be damaged and stuff, and it will lead to, of course, hematuria. However, since it damages the collagen, not just the glomerula, it damages the collagen in the whole body, it will also lead to hearing loss and eye abnormality. So if you have a patient who has hematuria, which is nephretic syndrome, and then who has also hearing loss and eye abnormality, think of Alport syndrome because all of these have collagen. Okay, on electron microscopy, we will have abnormal splitting and lamination of the basement membrane and thickening and thinning. Like the basement membrane is like disrupted. It has thickening, thinning, splitting, everything, okay? That's because it doesn't have enough collagen, and we call it basket wave appearance. So if you have this basket wave appearance, which is thinning, thickening, splitting, يعني رايح فيها basement membrane, and you have hematuria, hearing loss, eye abnormality, that's definitely Alport syndrome. That's the fourth nephritic syndrome. Okay? So now we covered four nephritic syndromes. All of these will only have hematuria, proteinuria, hypertension, يعني the bare minimum of a nephritic syndrome. However, it doesn't cause like end stage renal disease renal failure وفشل كلوي ولازم dialysis ومدري شو. No, they only cause hematuria, proteinuria. If we let them without treating them, okay, they may cause something, okay? However, there is a group of diseases called rapidly progressive glomerulonephritis, RBGN. These are diseases that cause nephritic syndrome, so it's still hematuria, but it's very rapidly progressing that it leads to renal failure very quickly if it's not treated, okay? These are group of diseases that lead to end-stage renal disease يعني almost immediately. What's special about all of these? All of them lead to this crescent formation. So the glomeruli usually is just this, okay? In all the examples we've discussed, it's just a glomerula. But in rapidly progressive glomerulonephritis, it will lead to this crescent shape formation. And this is a sign of like rapidly progressive glomerulonephritis. This is end-stage renal disease. So these people will have renal failure. They will require dialysis and stuff. So once you see in a case that someone suddenly developed end-stage renal disease and renal failure and stuff, pick this one, the one that have crescent formation, because that's rapidly progressive glomerulonephritis. Now, rapidly progressive glomerulonephritis, it divided to three groups. Didn't I say it's a group of diseases? It divided to three groups. It's based on the immunofluorescence thingy. Didn't I say it's granular most of the time? Here, it divided to three. First is linear. Second is granular. Third is post-immune or nothing. Like we do the immunofluorescence and the picture doesn't have any green. It's almost black. So let's start with the types. First type is the linear pattern. As you can see here, it's linear. It's not like dots, somewhere there is, somewhere there is not. Here, it's continuous. It's like a line. Because here, the immune complex deposition or the immune antibodies are attacking the basement membrane. Earlier, it's under the basement membrane, above the basement membrane, on the mesangium, stuff, okay? Here, it attacks the basement membrane. It's like on it, like a line. So it aligns the whole basement membrane and it will look linear, okay? So this is the first disease, linear immunofluorescence, rapidly progressive glomerulonephritis. And it's mainly anti-GBM or Goodpasture syndrome. So what are these diseases? Anti-GBM is type of rapid progressive glomerulonephritis. Since it's type of it, it will lead to crescent formation. We agree on that. Any rapid progressive glomerulonephritis will lead to crescent formation and renal failure. What's special about anti-GBM? It's autoantibodies against the basement membrane from the name. Antibodies against glomerular basement membrane. Okay, that's why it's linear and that's why it had this shape. One type of this is Goodpasture syndrome. What is Goodpasture syndrome? It's autoantibodies against the basement membrane in the kidney and lungs. Okay, so anti-GBM is autoantibody against the basement membrane in the kidney. Okay, they will have hematuria, rapidly progressive glomerulonephritis, crescent formation, whatever. If it's Goodpasture syndrome, it's autoantibodies against basement membrane in both kidney and lung. So in kidney, you will expect hematuria. Since it's also in lungs, you will expect hemoptysis. So if you have a patient who presents with nephritic syndrome, hematuria, end-stage renal disease stuff, and hemoptysis, يعني they are coughing blood, that's a sign that there is a lung involvement. And this is Goodpasture syndrome. Okay? That's Goodpasture syndrome. We finished the linear, it's just Goodpasture syndrome and anti-GBM. Then we have the granular. Granular, we already discussed them, which is PSGN and DPGN. Post-streptococcal glomerulonephritis and diffuse proliferative glomerulonephritis. And as we said, if it's subepithelial, it's PSGN, since it's PP. If it's subendothelial, it's DPGN. Damn. حرقنا عليكم السيشن. Damn. يب هير معلش. where we are. Yeah, here. If it's subendothelial, then it's DBGN. If it's subepithelial, then it's PSGN. These, PSGN and DBGN, are considered in rapidly progressive glomerulonephritis اللي هم بيعملوا لكم crescent formation. انتوا بس just memorize the pictures, okay? Then post-immune. As you can see here, يعني it's barely green. You barely can see anything. يعني قارنوها مع هاي. شوفوا قديش ال green is very shiny. Here the green is also shiny. Here there is barely any because there is no autoantibodies. It's ANCA diseases. I think you guys finished CVP and you already studied vasculitis. So I don't want to go deeply in these, but last type of rapidly progressive glomerulonephritis, the one that cause end-stage renal disease and crescent formation and stuff, is the post-immune. يعني ما في there is no immune cells here, so it doesn't show anything on the immunofluorescence, and it's mainly the ANCA diseases. You know, P-ANCA, C-ANCA, Wigner disease, and stuff. So these are the three types of RPGN. Is everything clear? Am I going too fast, going too slow? Tell me.
Everything's clear, thank you.
Okay. So shall I continue? ما حدا عنده أي question?
As you said, ما راح يجيبون بس صور ويقولون هذا ايش صح؟ لازم يجيبون سيناريو.
يا لازم يجيب بنحل أسئلة باست إن شاء الله في الآخر كلهم بيكونوا كيس وبعدين الصورة and you just need to solve يعني
تمام.
من
thank you.
الصورة الحل بيكون الصورة السؤال بيكون يعني لازم تطلعي الدايجنوز لازم تعرفي بي اس جي ان من الكيس وبعدين تحلي بيست على الصورة بنحل أسئلة كذا بس is everything clear من ناحية صور وشرح وكذا.
Yes, everything is fine, thank you.
Okay, now we will go to nephrotic syndrome. So these are not inflammation, these are damage to either basement membrane or podocytes. If we damage these, we will have proteinuria, بس ما في hematuria. If someone has proteinuria without hematuria, that's nephrotic syndrome. It's either damage to basement membrane or podocytes. They will have other presentation اللي هم edema و hyperlipidemia and stuff, بس خلاص we will not go through them again. Now we will talk about the diseases under nephrotic syndrome. First one is minimal change disease. From the name, it's minimal. يعني it's barely nephrotic syndrome. It's not that يعني damaging and stuff. So minimal change disease is a nephrotic syndrome due to effacement of podocytes. يعني شفتوا من شوي كان هذا الاندوثيليوم بعدين عليه basement membrane وبعدين عليه البودوسايتس كده طالعين. They are projecting in a very long way. In minimal change disease, there is effacement. يعني they are not projecting very well. It's like this, and then they are like that. So they are effaced. Okay? So minimal change disease is a nephrotic syndrome that causes proteinuria and stuff due to effacement of podocytes. ما في inflammation, ما في damage to anything. It's just the podocytes that are effaced. Okay? It leads to selective proteinuria. يعني we don't lose all proteins. We only lose albumin. Okay, which is the most important one, as it's very selective. It's only make you lose albumin. So minimal change disease, a nephrotic syndrome that causes selective proteinuria, which is albumin, and it's due to effacement of podocytes. It mainly affected children, and يعني to link it, it's called minimal change. Minimal يعني أوطى شيء. And who is the youngest population? Children. فيعني minimal change disease, since it's minimal, it affects minimum people, which is children. Okay. Since it's effacement of podocytes, أصلا we can't see podocytes on the light microscopy, so light microscopy will appear normal. يعني we can't see anything. This is the normal glomerula أصلا, because it's effacement of podocytes. We can't see that. In immunofluorescence, we also can't see anything because immunofluorescence, from the name immunofluorescence, it makes immune cells shiny. And minimal change disease is effacement of podocytes. There's no immune cells, so it's barely anything, barely any green. Okay. However, in electron microscopy, we will have effacement of podocytes. So as you can see here, هون it's normal. You see podocytes projecting هيك طالعين. Here you have them effaced. يعني if you look here especially, barely كلهم هيك خط حتى هون خط. By the way, صور الاختبار should be more clear than these. بس يعني as you can see here, it's projecting. Here it's like بالعرض. Okay, so it's effaced. That's minimal change disease. Okay. Effacement of podocytes treatment is just steroids. It's very responsive to steroids, and that's very important. Now, the other disease is focal segmental glomerulosclerosis from the name. By the way, this is also nephrotic syndrome, so it will cause proteinuria. From the name, it's focal, means it's only in one area of the glomerula. Segmental, it's like if it's focal, let me explain again. So we here have many glomerula. like 1, 2, 3, 4, let's say. Focal means it's not in all of them, it's like in 1 or 2 of them. So maybe only these two. Segmental means it's not in the whole all glomeruli, it's like part of it. So focal, not all glomeruli, part of them. Segmental means segments of this affected glomeruli. So not the whole glomeruli is affected. What will happen? Glomerular sclerosis. So there is sclerosis and fibrosis of the glomerula. So here we have sclerosis, fibrosis here. So as you can see, just erase it. In focal segmental glomerular sclerosis, we assume here we have like two glomeruli. One of them is not affected because it's focal. Focal means it affects one. So only this one affected. Then it's segmental. This part, the above part, is not affected. Only the lower part is affected. But affected by what? Sclerosis. So there is sclerosis, fibrosis of the glomerula. So in light microscopy, there is sclerosis, as we can see here. In electron microscopy, focal segmental glomerulosclerosis also can cause effacement of podocytes. So we will also here have effacement of podocytes. So you barely see any podocytes. So focal segmental glomerulosclerosis is a nephrotic syndrome, which will lead to proteinuria and stuff. It causes two things: effacement of podocytes, like minimal change disease, and hyaline deposition in the glomeruli. Hyaline is like sclerosis and fibrosis and stuff. What are the risk factors? Who are the people who usually have focal segmental glomerulosclerosis? HIV patient, people who have sickle cell disease, heroin intake, African American, and NSAID intake. Anyway, يعني focal segmental glomerulosclerosis affect people who have bad behavior. يعني HIV patient, heroin intake, NSAID intake بشكل مجنون. And also to other population اللي هم sickle cell diseased people and African American. These people also have high chance of having focal segmental glomerulosclerosis. But most of the cases, it's either the NSAID one or HIV or heroin intake. Okay? So, in light microscopy, we said there is focal segmental glomerulosclerosis. So some of the glomeruli affected, some are not. A segment from the glomeruli is affected by what? Sclerosis. On electron microscopy, there is effacement, and the most important thing here that it doesn't respond to steroids. When they ask you a question and they say it doesn't respond to steroids, most likely they are referring to focal segmental glomerulosclerosis. I heard that this disease is not covered well in your lectures. So I wanted to include it because it's a very high yield thing, and there are like questions about it in the past. Third disease that causes nephrotic syndrome is collapsing glomerulopathy. This disease is not high yield. Honestly, I don't think you will be asked. So it's just one important info I want you to know about it, that collapsing glomerulopathy affects the visceral epithelial layer, which is podocytes. يعني خلاص at this point minimal change disease affects podocytes, effacement. Focal segmental affect podocytes. And now collapsing also affect podocytes. I just want you to know this. Collapsing glomerulopathy affect visceral layer, which is podocyte, because there was an MCQ question about this. Collapsing glomerulopathy affects which layer? Podocytes. But this is the only information I want you to know. ولا حتى الpicture. If you want to memorize the picture, memorize it, but there are no question about it. Now we finished 3 diseases in nephrotic syndromes. Now the fourth, membranous nephropathy. From the name, it affects the membrane. طب, this in the name, does it say proliferative? No. So it doesn't cause proliferation of the membrane, because there is another disease called proliferative membranous or membranous proliferative. Here it's just membranous. So it doesn't cause proliferation. But what does it cause? It causes thickening. So this is the basement membrane and then it gets thickened. Okay? Why does it get thickened? Because there are immune complex deposition. So in membranous nephropathy, it's a nephrotic syndrome, meaning it will cause proteinuria. But why? What happens due to thickening of the basement membrane? Okay, so the basement membrane is thin, then it becomes thick. طب ليش? What happens? It's due to subepithelial. Okay, epithelial immune complex deposition. So membranous nephropathy is a disease that's causes thickening of the membrane due to subepithelial immune complex deposition. That's why here we will have a linear immunofluorescence. ليش linear؟ لأنه it's mainly يعني related to the membrane. I know this is confusing. من قبل قلت subepithelial حيكون granular، بس خلاص انتوا guys just memorize it انه everything else في هذوليك granular except here. صح انها subepithelial بس the disease name is membranous, so it's gonna be linear. Okay, because the disease name itself is membranous, so it's on the membrane and subepithelial, so it will be linear. I know confusing, but memorize it. I know. بس يعني you need to memorize this information. By the way, the picture here is changing لأنه it's two picture for this. As I said, it causes thickening of the basement membrane. So as you can see here, the basement membrane is very thick, even here. And this picture usually they use in the exam. So it's very thick, very black. So that's membranous nephropathy. It leads to proteinuria, no hematuria, like microscopy thickening. Did I put granular here? It should be linear. It is linear, I guess. I will double check and tell you guys. بس هلا خلونا على thickening of basement membrane و electron microscopy. It's subepithelial. Okay, subepithelial. Please focus because there are other diseases that are subendothelial, but this one is subepithelial. You want to say membranous B, subepithelial B, that works. It also have spike and dome appearance. So it goes under the membrane subepithelially and causes spike and dome. What's spike and dome? It means like this. So here it's a spike, here it's a dome, here it's a spike here, or actually like this. Yes, like this. So this is a spike, that's a dome. That's a spike. So here it's a dome, then a spike, then a dome, then a spike, then a dome and spike. So spike and dome appearance. So last time, membranous nephropathy, nephrotic syndrome due to thickening of basement membrane. There are subepithelial immune complex deposition. It will lead to proteinuria, thickening of basement membrane, immune fluorescence deposition. I will make sure. Maybe it's granular and it's not linear. I will double check. In electron microscopy, it will lead to subepithelial deposition. B for B, membranous subepithelial, spike and dome shape. Last thing is SLE. You remember the slide of SLE? It causes 5 diseases. This is the 5th disease, the one we said we will talk about it later, which is membranous nephropathy. It's caused by SLE, it's caused by other stuff, such as NSAID intake, but mainly SLE. Okay, is this disease clear? I will just check سريع عشان ما ألخبطكم.
Yes, it's clear.
Okay, just 1 minute, I will check. Maybe it's granular صراحة. Okay, it's granular. So I will edit this slide. It's not linear, it's granular. طب الحمد لله it's granular. This is better. I thought it's confusing أصلا. Okay, membranous nephropathy is granular because it's subepithelial. It doesn't damage the membrane itself, so it should be granular. Okay, because it's subepithelial. It's like the other diseases. Okay, clear? Last time, it's granular, not linear. That's a typo.
So
I'll
if
continue.
anti-membranous, it will be linear,
Yeah,
صح?
only anti-GBM so far is linear and good pasture اللي هم مع بعض يعني. But
Thank
here it's granular.
Okay.
Okay, we will cover other stuff that might be linear بس هلا خلاص it's granular. Now diabetic nephropathy. This is also a nephrotic syndrome. So this is the 5th disease about nephrotic syndrome. It's called diabetic nephropathy. So it's due to diabetes mellitus. Why does that happen? Because glomerular basement membrane is thickened. Like, what is this disease about? Diabetic nephropathy, if someone have diabetes, they will have very high amount of glucose. This glucose will cause glycosylation of the basement membrane. Yani glucose will bind to the basement membrane and it will cause it to be thickened. Okay? So it will cause something similar to membranous nephropathy, اللي هو thickening of the basement membrane, but that's stage 1. For stage 1 of diabetic nephropathy, the glucose will bind to the basement membrane and cause thickening. If we left that وما صححنا الجلوكوز and we corrected the levels and stuff, we will reach stage 2, which is KW nodules. So here we will have nodules formation. These nodules are يعني full of glucose وimmune stuff وهيك يعني ما لكم دخل بإيش it's made of. بس يعني first it will lead to thickening of the membrane because the glucose bind to the membrane and cause it to be thickened. Okay, on both what's called light microscopy and electron microscopy. If we left that, this glucose will يعني bind to each other stuff وهيك وهيعملوا لكم nodule. This nodule called chemical Wilson nodule أو KW nodule أسهل. Which is nodular glomerulosclerosis يعني في glucose وبعدين في fibrosis of this nodule وهيك يعني خبصة بس it doesn't matter. المهم إنه first there is thickening and then if we left that we will have nodules. إيش اسم هذول النوديولز؟ KW nodules. As you can see here. طيب happen in which disease? Diabetic nephropathy. That's the only thing you need to know about diabetic nephropathy. It's caused due to glycosylation of the basement membrane. First stage, thickening. Second stage, KW nodules. That's it. طبعا you need to identify this in the pictures بالOSPE. Last disease in nephrotic. Now that's the sixth disease, I guess. Amyloidosis. Amyloidosis is due to amyloid deposition. هلا هو في disease تاني كبير اللي هو amyloidosis. في amyloid deposition in the kidney وبالسكن وبالبون marrow. But here we only need to focus about amyloid deposition in the kidney. So amyloidosis is a systematic disease lead to deposition of amyloid in the tissue. If this amyloid is يعني got deposited in the kidney الجلوميرولس itself, we will have nephrotic syndrome. طيب nephrotic syndrome يعني ايش؟ يعني proteinuria. تمام؟ That's it. Amyloidosis, deposition of amyloid in the kidney. طيب ايش بيصير؟ On light microscopy we'll have eosinophilic depositions. ايش هم eosinophilic depositions؟ هم الاميلويد. So here you can see amyloid في what's called في الكدني. فممكن تقولوا هذا بيلخبط بينه وبين focal segmental glomerulosclerosis. You will know from the case itself. اوكي؟ يعني لو الكيس واحد عنده اتش اي في او هيروين يوزر او افريكان امريكان that's focal segmental glomerulosclerosis. If it's someone ما عنده شيء ولسه في خصائص لاميلودوسيس we will talk more about, بس يعني لو حدا ما عنده اشياء اف سي جي اس that's most likely amyloidosis. طيب amyloidosis مثل ما قلنا في eosinophilic deposition in the mesangium. ايش كمان في الاميلويد نفسه we can stain it with something called congruent stain. If we did that it will have apple green preferences appearance اللي هو هذا الأخضر. اوكي بس amyloidosis amyloid deposition in the kidney it will lead to nephrotic syndrome. In light microscopy it will appear as eosinophilic depositions in the mesangium يعني في النص وهيك. شو اسمه to differentiate it from other diseases we do something called Congo red stain. On Congo red stain it will appear as apple green preferences which is this, and that's special for amyloidosis. يعني this is let's say buzzword. يعني لو لقيت Congo red stain في ال question وفي apple green preference definitely go for amyloidosis مهما كان الكيس. Okay, so that's amyloidosis. Now we finished both nephritic and nephrotic diseases. الديزيز اللي حكينا عنها اما نفرتك او نفروتك. اوكي now we will talk about some diseases that cause mixed nephritic ونفروتك. يعني البرزنتيشن حيكون في هيماتوريا يعني ار بي سيز وكمان البروتين ليفل اكثر من 3.5. اوكي that's mixed nephritic and nephrotic diseases. طب ايش هم الديزيزز؟ هو one disease has two types which is membranoproliferative glomerulonephritis from the name. من زمان اخذنا ممبرينو جلوميرونيفرايتس يعني الممبرين من دون proliferation بس الممبرين membrane thickening. اوكي now we have membrano proliferative يعني في proliferation of the membrane. كمان من قبل اخذنا diffuse proliferation تبع الاس ال اي. هذا فيه diffuse proliferation كله عم يصير له proliferation endothelium mesangium. هون proliferation بس في الممبرين. اوكي so we have membrano proliferative glomerulonephritis proliferation and thickening of the basement membrane. Okay, MBGN. MBGN has two types. Okay, first type MBGN type 1 it's diffuse proliferation and thickening of GBM. يعني basement membrane is thickened and proliferated. تمام؟ ليش؟ due to immune complex deposition. طب where are they depositioning? Subendothelially. طيب من شوي حكينا عن membranous nephropathy بس membranous سادة من دون proliferation وقلنا إنها subepithelial. طيب تاني ديزيز سب اندوثيليال. ايش تاني ديزيز؟ ام بي جي ان تايب 1. ام بي جي ان تايب 1 is sub endothelial. I don't have mnemonic for this لانه ما في حرف دي في الممبران بروفيتيف. بس انا بس بدي اياكم تحفظوها بالترتيب. انا ايش شرحت اول شيء؟ بي اس جي ان. اول شيء شرحت بي اس جي ان كانت ايش؟ سب ابيثيليال بي. تاني شيء ايش شرحت؟ اس ال اي ايش كانت؟ دي سب اندوثيليال. هون نفس الشيء ممبرينس ساده. اول شيء شرحته ايش كان؟ سب ابيثيليال. طب ثاني شيء ممبرينو بروفيتيف تايب 1 ايش حتكون؟ دام اول شيء كان سب ابيثيليال ايش ثاني ديزيز حيكون؟ سب اندوثيليال. اوكي سو ام بي جي ان من اسمها ممبرينو بروفيتيف يعني فيها ممبرينس thickening and proliferation of the basement membrane. ليش؟ immune complex deposition. طيب وين؟ It's the second disease I've discussed it's subendothelially. On light microscope when you have يعني membranous thickening كان بس كان إلها name او فرجيتكم شكلها هون. if there is thickening and proliferation هذا اسمه ترام تراك appearance، اللي هو زي هيك بصيروا هيك مثل او هيك دوائر كأنه، ما أعرف صراحة how to explain it, onion or something, I don't know. It's the tram track appearance. So membrane proliferative glomerulonephritis thickening and proliferation lead to tram track appearance. Okay. طيب how it will appear بالlight microscopy؟ قلنا tram track appearance. طيب immunofluorescence granular. ليش granular؟ لأنها sub endothelial. احنا قلنا إذا sub epithelial granular، إذا sub endothelial كمان granular، إذا on the basement membrane then it's linear. تمام؟ ف MPGN type 1 tram track appearance granular and subendothelial. As you can see here it's under the endothelium. تم؟ هذا MPGN type 1. Let's go to MPGN type 2. MPGN type 2 زي type 1. It's diffuse من الاسم diffuse proliferation and thickening of GBM. membranoproliferative thickening and proliferation of the basement membrane. طب ليش؟ immune complex deposition. طيب نفس الشيء، ايش الفرق؟ It goes to the GBM itself، يعني basement membrane itself. يعني MPGN is proliferation and thickening of the basement membrane in type 1 و type 2. ليش؟ immune complex deposition in type 1 type 2. بس in type 1 immune complex subendothelially. In type 2 it's on the basement membrane itself. طب if there is on the basement membrane itself how it will appear on the immunofluorescence؟ linear. على شكل خبط ايوه. it's linear تمام because it's on the membrane itself. it's named membranous، بس ما بيهمنا ايش النيم، بيهمنا انه وين الاميونوفلورسنس عم يروحوا، الاميون ديبوزيشن عم يروحوا. if it's on the basement membrane itself then it's linear. تمام. وهون كمان we can see انه الجي بي ام انتوا ليش طالعين؟ ايوه في dense deposits على البيسمنت membrane. و lastly it doesn't have tram track appearance. it will have just proliferation and thickening of basement membrane اللي هو سادة، يعني ما في something special. and these are just memorization يعني. Is it clear? This is the toughest disease. Honestly ما عليه كثير أسئلة. There is tram track appearance thingy، بس غير هيك ما بشوف عليه أسئلة كثير في الأوسبي، بس في الام اس كيو عليه أسئلة definitely. ف is it clear؟
Yes, clear.
Okay. This is, I know, a very complicated disease. I just want to highlight one last thing إنه linear is only in two diseases اللي هم anti GBM و good pasture اللي هو نفس بعض almost. Okay. و membranoproliferative type 2. Okay, because these have immune complex on the basement membrane itself. So linear only in two things. However, granular is almost in everything else غير اللينير والبوسي immune اللي هم تبعت الفاسكولايتس وانكا وستاف. So membranous is granular. Membranoproliferative type 1 is granular. Type 2 is linear. اوكي. خلص هلا احنا honestly خلصنا اصعب شيء في the whole thing اللي هم هدول diseases. From OSPE I heard your exam is 10 questions. I would say 3 or 4 بيكونوا عن هدول. Now we will go through other diseases, tumors و necrosis و ischemia وهيك، بس it's way easier, more chill. You will not see these notes anymore I guess أو barely some because خلص يعني everything now will be pictures و some information about the disease. Now we have a disease called acute tubular necrosis. هلا احنا اتفقنا انه هذا الارتري، بعدين هون الجلوميرولا، بعدين هون الارتري مرة ثانية، وهون البومن كابسول. هلا بعد البومن كابسول اليورين goes through tubules proximal convoluted distal convoluted وهالقصة كلها. So these tubules have arteries around them that are supplying them. زي هون glomeruli هاي tubes، هذا التيوب هيك، هون في artery supplying it. إذا صار في less blood supply أو ضربنا الارتريز اللي هون حيصير في ischemia على التيوبيول. أوكي. This will cause ischemic acute tubular necrosis، يعني necrosis أو injury to the renal tubules. بتصير due to two things. أول شيء ischemia اللي هو less blood supply، hypovolemia، blood loss. فهيك بصير عندنا tubular necrosis يعني damage to the tubules. في other type اللي هو toxic type اللي هو مثلا ناس بياخذوا overdose of a specific drug. This specific drug damage tubules and it will cause also tubular necrosis. ايش الفرق؟ في الاسكيميك it will be يعني not continuous، يعني هون في بعدين هون في بعدين هون في بعدين هون ما في بعدين هون في، فإتس segmented. اوكي. because هون blood supply is damaged otherwise هون blood supply is fine. here it's not damaged. فالاسكيميك type it's patchy يعني segmented ما أنا continuous. however التوكسيك type الدرج أو البويزن الشخص أخذه will pass through the whole tubule, it will damage the whole thing. ممكن أجيب لكم هاي الصورة ويقول لكم acute tubular necrosis two types ischemic و toxic. which one is ischemic الباتشي اللي ما لها continuous. طب which one is toxic الcontinuous. بس that's what I want you to know for tubular necrosis here. طيب on light microscopy حيكون هيك في نكروس area of necrotic tissue يعني هاي الكدني وكلها لونها بني فاتح وهيك الا اريا بني غامق. ايش في نكروسز. كمان احنا اتفقنا انه هاي الجلوميرولا هذا الشكل هيك المشخبط هذا الجلوميرولا جنبها بيكون في هيك تيوبز هذول التيوبيولز. التيوب بيكون بالعادي ثن الا في تيوبولار نكروسس حيكون ثيك زي هون تشوفوا كيف ثيك. وفيه كمان هايبر سيلاريتي يعني فيه هيك نيتروفيلز اللي هو انفلاميشن عم يصير فيه. فذاتس what I want you to know from tubular necrosis two types ischemic و toxic. ischemic patchy toxic يعني على طول التيوبيول. grossly it will appear different color أغمق بس. on light microscopy thickening of the tubular membrane مو الجلوميرولا ما لها دخل بالجلوميرولا. as you can see هون الجلوميرولا ما فيها شيء التيوبولز هي اللي متأثرة. كمان it has a specific cast we will cover it later بالcats but it has granular brown cast بس we will cover it later. خلصنا tubular necrosis. now we have renal cystic disease. هلا هاي الكدني it may develop a cyst هيك cyst اللي هو fluid filled يعني think mass we will call بس مو mass it's a cyst it's fluid filled mass. it's fine sometimes it doesn't cause anything. I know many people who have simple renal cyst يعني بس هيك cyst على الكدني it doesn't cause anything but there are diseases that cause some stuff so now we will cover them. first we have multicystic renal disease. I don't want you to know the disease I want you to know OSPE stuff. multicystic renal disease عندنا مليونين ألف cyst على الكدني we can't tell اصلا that this is kidney. this doesn't look like a kidney at all يعني بس هيك cyst فوق بعض. فمالتي cystic renal dysplasia مليان cyst على الكدني that it lose its structure it disturb the structure. فذاتس multicystic renal disease. كمان other identifying feature انه as you can see here في cartilage. شوف هون السيست سودا بس هون ابيض ليش؟ لانه في cartilage. فمالتي renal dysplasia مليان cyst في الكدني we can't tell that it's a kidney in the first place and it has cartilage. كمان باللايت microscopy here it has cartilage this is cartilage. تمام. بس that's multicystic renal dysplasia. I don't want you to know why symptoms لا بس الصورة. this picture is multicystic renal dysplasia. ليش؟ في cartilage we can't tell that this is a kidney. تاني disease autosomal dominant polycystic kidney disease. هذا كثير مهم MCQ SAQ OSPE everything. From the name it's autosomal dominant يعني it's an autosomal dominant mutation to a gene. okay. polycystic kidney disease causes many cysts on the kidney. تمام. autosomal dominant polycystic kidney disease autosomal dominant mutation to PKD1 و PKD2 gene. هذا مهم للام سي كيو. اوكي so it's ADPKD فالجين موتيشن حيكون ايش؟ بي كي دي من الاسم ادي بي كي دي بي كي دي. اوكي. cause defect in polycysteine اوكي which cause multiple cysts. من اسم الجين او البروتين polycysteine what it will cause many cysts من الاسم polycysteine. فautosomal dominant polycystic kidney disease autosomal dominant mutation to PKD من الاسم كمان causes mutation to polycysteine causes multiple cysts in kidney. فهاي الكدني مليانة cysts we can still tell it's kidney ما في cartilage. كمان هون it's still a kidney ف it's يعني غير مالتي هذاك اللي قبله يعني. clinically we will have hematuria. Okay, we will have liver cysts. This is very important. Autosomal dominant polycystic kidney disease will have cysts in both kidney and liver. والcyst من برا يعني we can tell there are cysts here. تمام. It will also cause perianeurysm. This is MCQ stuff ما لي دخل فيه. It may lead بس يعني guys فكروا فيها. Polycystic kidney disease many cysts. hematuria ما لي دخل فيها بس يعني it causes cysts بالكدني cyst بالليفر. وperianeurysm هي مثل aneurysm of an artery which looks like a cyst. عشان هيك it causes many cysts بالكدني بالليفر وحتى بالبرين يعني بالارتريز تبعوته it causes aneurysm which is also similar to a cyst. It may lead to end-stage renal disease. On light microscopy we will have multiple cysts on liver وكدني بس ما في cartilage. That's important. Okay. That's autosomal dominant polycystic kidney disease. Now we have another disease called autosomal recessive polycystic kidney disease. من الاسم autosomal recessive so it's autosomal recessive mutation. since it's the second disease والاول كان بي كي دي، الثاني ما حيكون بي كي دي الجين. So it will be PKHD. اوكي، انتوا احفظوها بس هيك يعني. It's the second disease. It's recessive, not that important. فالجين حيكون مو PKD entirely. It will be PKHD. Autosomal recessive polycystic kidney disease، رغم الاسم اسمه polycystic، برا ما بنشوف اي cyst. يعني here we don't see any cysts on the in the cortex because it's recessive. يعني it's let's say mild, not that highly cystic. فالسيست حيكونوا only on the inside. يعني هون شوفوا في cysts جوا بس ما في cyst برا. هون كمان هاي الكدني ما في cyst برا. It's just enlarged kidney. هون on the CT scan we have cysts from the inside only، ما في من برا أي cyst. فأوتوزوم، وحتى هون يعني شوفوا grossly cyst بس من جوا ما في من برا. in autosomal recessive polycystic kidney disease it's recessive يعني mild let's say. ف cysts بس جوا ما انهم برا. the organ looks enlarged بس ما في cysts. اوكي، and it's due to PKHD. من قبل كان البروتين الافكتد اسمه بوليسيستين. فبوليسيستين لانه في multiple cyst. هون ما في multiple cyst، السيست ما انهم طالعين لبرا. فit's gonna be fibrocystin another cystine بس يعني fibrocystin. اوكي، so it causes multiple renal cysts innerly يعني من جوا. وكمان causes fibrosis of the liver لانه اسم البروتين فايبروسيستين. فايبرو حيكون في fibrosis وين؟ في الليفر. ف autosomal dominant causes cysts in the kidney and liver. Autosomal recessive causes inner cyst in the kidney and fibrosis of the liver. Okay. It affects the children and infants. صح, one more thing. Autosomal dominant affects adults. شوف كيف autosomal dominant is written as AD, which is similar to adults. فautosomal dominant affect adults. Autosomal recessive we said it's mild, خفيف, minimal. فit affects minimal people اللي هم children, infants وهيك. Okay. It causes end stage renal disease in children, liver fibrosis, مش cysts, fibrosis. Hypertension or portal hypertension. Grossly, it will have enlarged fibrosed liver, enlarged kidney without cyst on the outside. Okay, just in the inside. One last time, this slide father. Okay, we have autosomal dominant, we have autosomal recessive. Autosomal dominant affect the adult لأنه اسمه autosomal dominant autosomal recessive affect the children. Autosomal dominant will cause cysts on the outside. Autosomal recessive will cause cyst in the inside. Autosomal dominant will cause on the liver كمان في cysts. Autosomal recessive will cause fibrosis of the liver. أسماء الجينز is not important for the OSPE but they are important for the MCQ. That's why I covered them. وهاي الصور طبعا مهمة. Here the cysts are inside not outside. Here it's just grossly enlarged not cystic. Memorize the pictures. Okay, now we finished the three diseases of the cysts. هلا الرابع medullary sponge kidney. من الاسم it's medullary. فوين الافكت حيكون؟ on the medulla itself. هذا فوق cortex، هون medullary junction، هون medulla. Medullary sponge kidney it will affect the medulla itself. What is this disease? It causes multiple cysts in the medulla. فمثل ما شايفين هون في كثير cysts innerly بس مو innerly حتى في الكورتكس، لا بس في الميدولا. فذاتس medullary sponge kidney. It looks like a sponge من كثر السيستس اللي في الميدولا وبس. That's it يعني. That's what I want you to know. This picture وإنه medullary sponge kidney affects the medulla بس. It doesn't affect cortex ولا الجنكشن بس الميدولا. On the other hand we have medullary cystic kidney. من النيم it's also medulla بس ما انها sponge لأنه ما في كثير cysts in the medulla that looks like a sponge. Here it looks like a sponge. Here no. وتاني شيء it's not in the medulla, it's in the mediocortical junction. يعني هون بين الكورتكس والميدولا بالفاصل اللي بينهم في cyst. هيك one cyst, two cysts. مو انه they look like a sponge. فاهمين قصدي؟ that's why it's medullary cystic kidney. I want to differentiate. Medullary sponge kidney, it's multiple cysts in the medulla that look like a sponge. Medullary cystic kidney, it's cyst in the mediocortical junction and it's just like one, two cysts. فمانها spongy. Okay? That's it for medullary cystic kidney. Last disease in the cystic, I guess, dialysis associated cystic disease. هون من الهيستوري نفسه you can tell that this is the diagnosis. ليش؟ بيقول لك patient عنده renal failure and he's on dialysis. ايش حيكون الدياجنوسيس؟ dialysis associated cystic disease. It is multiple cysts in the cortex, medulla, بالنص برا في كل مكان for dialysis patient. بس that's it. هلا اللي بعده is just simple stuff بس I just want to review autosomal dominance in adults. autosomal recessive in children, dialysis associated in dialysis patient. تمام؟ واضحة I guess. Now we will talk about simple renal cyst. يعني من شوي كان عندنا كدني مليانة cysts جوا برا بالنص مدري وين. simple renal cyst is just one cyst على الكدني، يعني هاي كلها كدني وفي عليها cyst very benign، ما بتعمل أي شيء. no renal failure no renal effect. People usually أصلا born with this thingy، يعني هم بينولدوا عندهم simple renal cyst. That's just a simple cyst on the cortex, no symptoms or anything. I just want you to identify it في الإكزام. جاب لكم واحد عنده قالوا له عنده سيست وما في اي سيمتوم، ما في اي شيء، خلاص هي سمبل رينال سيست. تمام. في لها classification. This is kind of annoying. This is radiology by the way، بس خلاص I want to cover it مع simple renal cyst. So as we said we have a kidney and we have a cyst on it. We do imaging of it. Okay. We have something called Bosniak classification. It's four types. Okay. اول تايب هي بس سيست من دون سبتم، يعني شايفين هيك كرة من دون سبتم. شوفوا هون كيف هيك كرة ما في سبتم، بس هذا بوزنياك 1. الثاني بوزنياك 2 few symptoms، يعني اما من واحد لثلاثة which is very few، وكمان كثير رقاق. فشوفوا هون كيف السبتم الرقيق and it's just one symptom. ف if it's just a ball that's one. if it's هيك بس في يعني minor line let's say أو few symptom يعني هيك، هذا 2. في 2 له يعني identification تاني اللي هو 2F اللي هو multiple few lines. يعني هون كان one line هذا 2، لو في multiple few lines هذا 2F. اوكي. فشوف هون كيف في هيك multiple few lines هذا 2F. it's still 2 because it's very يعني thin lines بس multiple أكثر من واحد. اوكي. Last, then we have three, Bosniak 3. You see السبتم is thick أو irregular، يعني هون الكرة بس هيك thick و irregular ومشخبط ومدري شو. هذا بوزنياك 3. 4 اللي هو most severe، في nodules وفي هيك كتير irregularity fibrosis، يعني الدنيا ضايعة فيه. ف for one last time here we have a cyst على الكدني. It's very benign ما بتعمل أي شيء. We have four classification of it. One is just a ball ما فيها أي شيء. Two is either a ball with the very few thin lines هذا اسمه 2، أو 2F اللي هو multiple thin lines. أوكي. 3 is very irregular lines ومتشقلبين ورايحين فيها. 4 is يعني في نوديول، يعني هيك في كرات والخطوط كثير irregular وهيك. ف I want you guys to identify it in the exam. Most of the questions were Bosniak 2، بس يعني إذا كرة فاضي 1، إذا خطوط خفيفة، إذا قليل 2، إذا كثيري 2F، إذا الخطوط irregular ومتشقلبة ومدري شو 3، إذا في نوديولز والوضع رايح فيها هذا شو اسمه 4. هون ما بدي اياكم تلخبطوا كمان تقولوا لي هاي irregular، هذا مو irregular. it's still very few lines. شوفوا irregular هون كيف كلهم irregular. فاهمين قصدي؟ ف that's the differentiation. خلصنا الرينال cysts. is everything clear؟ لانه هلا خاشين على cancers وعالم تاني يعني تماما. is everything clear؟
Yes, everything is perfectly clear. Thank you.
okay. now we have ureter and bladder diseases. اول شيء بس عشان نكون واضحين، هاي كدني بيطلع منها renal pelvis، بعدين هذا اللي بيودي اليورين للبلادر is called ureter. Okay, it's lined by transitional epithelium أو urethelium. It's different than the one in the kidney. It's the same as the one in the bladder. Okay, it's called transitional epithelium أو urethelium. طيب let's start. First disease in the ureter، أصلا ما في غيره I guess. urethritis cystica. اوكي. من الاسم cystica يعني في multiple cysts on the ureter. هون شايفين هذا اليوريتر في cysts كثار. اوكي. وكمان اسمه urethritis يعني في عنا inflammation of the ureter. فمن الاسم urethritis cystica inflammation of the ureter that causes multiple cysts. بس urethritis cystica inflammation of the ureter that causes multiple cysts. طب ليش في inflammation؟ ليش في كرونيك انفلاميشن؟ يعني اما اوبستراكشن، يعني اليوريتر هيك ماشي وفي ستون مثلا هون او ستركتشر، او مثلا في شي تيومر از بلوكينج ات فصار في اوبستراكشن فصار عندنا انفلاميشن لان اليورين حيضل قاعد ويتجت انفليمد. او ريفلكس اوف يورين، يعني اليوريتر هيك ماشي وبيروح على البلادر وبعدين في اوبستراكشن في البلادر، مو في اليوريتر لا في البلادر. فاليورين will go up في اليوريتر and it will cause inflammation. المهم بدي اياكم بس تعرفوا الصورة. الأسئلة هيك يعني someone has inflammation of the ureter, which of the following is a complication. بيعطوكم صور أشياء عشوائية، بيكون هو هذا الحل ureteritis cystica. تم. very easy very simple. طيب تاني شيء عندنا يوريتر كونستراكشن سايتس. يعني هذا اليوريتر بيطلع يعني من الكدني وبينزل هيك وبيودي للبلادر. اوكي. آه، ممكن stones develop in the kidney and pass through. اليوريتر واسع مو كثير ضيق، بس there are at some point يعني it gets very narrow فالستون may lodge. اوكي. it's just three sites لأنه بيكون عنده relation مع other structure. أول وحدة at the uretropelvic junction، يعني أول ما بيطلع من الكدني بيكون ضيق شوي. أوكي. بعدين بيتوسع، بس هو بيكون ضيق شوي أول ما بيطلع بالكدني، فالستون may lodge here at the uretropelvic junction. if it lodged here اليورين حيضل عالق في الكدني وحيصير عندنا hydronephrosis و enlargement of the kidney. تاني شيء at the pelvic brim، يعني هيك اليوريتر نزل، بعدين هون عندنا الايورتا it got bifurcated وطلع لنا common iliac artery on the both sides، وبعدين اليوريتر pass through، يعني هون الiliac artery طالع وذن اليوريتر pass through it. when it pass through it it's gonna get constricted يعني، ف it will have a constriction site. فممكن الستون تعلق كمان at the pelvic brim، هو bifurcation of common iliac artery. ثالث شيء at the point of entrance للبلادر، يعني اليوريتر حيدخل للبلادر، البوينت اوف انترنس الدخلي نفسه ضيقه شوي، فممكن الستون كمان تعلق هون. فاللي بيهمني انه الستون it may lodge at 3 points. الاولى يوريتروبلفيك جنكشن اللي هو بين الكدني واليوريتر. ثاني شيء pelvic brim، يعني عند البايفركيشن اوف ايورتا it pass through الإيلياك ارتري وبيعلق الكومن إيلياك ارتري. ثالث شيء وقت بدها تدخل بالبلادر بيضيق شوي، فممكن الستون تعلق. اذا علقت الستون هون حيصير عندنا هيدرونفروسيس في كل هاد. اذا علقت عند الكدني بس يعني الهيدرونفروسيس حيكون في الكدني بس. تمام. خلاص خلصنا يوريتر. هلا البلادر، الموضوع شوي طويل فبير with me. البلادر is a structure that contain urine. اوكي. هاي البلادر it's lined by transitional epithelium او urethelium. تمام. very simple. هذا هو اليوريثيليوم transitional epithelium. it's lining it. اوكي. اذا صار عندنا inflammation of البلادر، يعني يمكن لانه واحد بيحبس اليورين تبعه كثير وانتم بكرامه، او حدا عنده infection or something. اوكي. ممكن يصير عندنا inflammation of the bladder. It's called cystitis. اوكي. if there is chronic inflammation حيصير عندنا شيء اسمه فون برانز نست. يعني هذا الترانزيشنال اوكي مش ناوي يضبط. ايوه. هذا الترانزيشنال ابيثيليوم get thickened وبيصير هيك as a nest. اوكي. فهذا اسمه فون برانز نست. اوكي. It's benign nest of urothelial cell. يعني هذا اليورثيليوم لأنه في كثير inflammation وبيكبر وبيصغر وهيك it will form a nest and it's here. Later on لو ضل الانفلاميشن شغال it will be like this، يعني ما عاد له connection مع الابيثيليوم نفسه. It's gonna be خلص on the inside لحاله. هذا اسمه فون برانز نست. ممكن سؤال يجي حد عنده cystitis inflammation وما عالج وما أخذ أدوية which of the following will happen to them، والحل فون برانز نست. simple صح؟ اوكي. Now we will talk about a structure that يعني وقت احنا بنكون فيتس او يعني ببطن الوالدة let's say هاي البلادر وهاي الامبليكس. اوكي. وفي structure هون called uricus. اوكي. made of something called allantois. هذا it connects البلادر بالامبليكس عشان الواحد يقدر يطلع اليورين من الامبليكس وهو في رحم الام. اوكي. بس ان الولد انولد هذا اليوريكس should be gone، يعني it should get fibrosed ويختفي and it's gonna be replaced by something called umbilical ligament I guess. yeah umbilical median umbilical ligament. اوكي. فوقت بنكون ببطن الوالدة واحنا لسه فيتس بيكون في connection بين البلادر والامبليكس. هذا الكونكشن اسمه يوريكس. اليوريكس ميد اوف الالانتويس عشان يطلع اليورين من الامبليكس. الواحد بيكبر بينولد وات ايفر this uricus should be obliterated وخلاص ما عاد في يورين يطلع من الامبليكس. it may stay however and it will cause something called patent uricus. يعني في كونكشن بين البلادر والامبليكس. فيعني ممكن تلاقي حدا كبير and he is يعني عم يطلع منه يورين من الامبليكس. اوكي، هذا هو بيتنت يوريكس. كمان ممكن يصير عندنا شيء اسمه يوريكال سيست. بدل ما يكون الخط هذا كله لسه موجود، لا، بيصير في اوبليتريشن هون واوبليتريشن هون، يعني بارشل، بس بالنص ما صار اوبليتريشن. يعني عندك انبوب سكرته من هون وسكرته من هون، من النص خليته مفتوح، حيصير سيست. فبصير عندنا يوريكال سيست. فهي يوريكال سيست partial closure of the what's called uricus. It will cause cyst in the uricus and it might become infected لأنه حيظل اليورين فيها حيظل عالق، لا فيك تطلعه من ورا ولا من قدام. ايش حيصير؟ حيظل اليورين عالق and it will cause an inflammation وهيك and it may lead to bladder adenocarcinoma. هلا خلونا نتفق على شيء. البلادر is made of transitional epithelium. فالمفروض الكانسر اللي يصير فيها هو يوريثيليال كانسر، بس in some point ممكن يصير عنا ادينوكارسينوما ايمت، اللي هو الكانسر تبع اليوريكس. اوكي، لان اليوريكس مو معمول من ترانزيشنال ابيثيليوم، معمول من اذر ابيثيليوم كولومينار او هيك. it will cause adenocarcinoma. كمان it may happen انه يصير عندنا squamous cell carcinoma، بس هذا في انفكشن. هلا ما بيهمني، هلا بيهمني شيء واحد، انه عندنا يوريكس و it may cause urical cyst اللي هو هذا الستراكشر. urical cyst may cause adenocarcinoma. بس هذا اللي انا بدي تعرفه. تمام تمام. هلا we will go through bladder cancers. هلا as we said البلادر معمول من transitional epithelium، وعندنا اليوريكس معمول من other epithelium اللي هو columnar او whatever. اوكي، ف bladder cancer ممكن يكون اما يوريثيليال ترانزيشنال اللي هو most common من الابيثيليوم نفسه تبع البلادر، ممكن يكون فيلس ادينوما او ادينوكارسينوما اللي هو كانسر اوف ذا يوريكس نفسه. وممكن يكون سكويمس سيل كارسينوما. سكويمس سيل بيكون من انفكشن اسمه شيستوسوما. شيستوسوما it will infect the bladder and cause squamous cell carcinoma. تمام. كمان في one case للادينوكارسينوما I don't think it's very high بس شفتها عندكم بالليكتشرز، اللي هو exophytic bladder. يعني البلادر should be in the pubic area، صح؟ في ناس يعني هون هذا شخص هذا كرشو، تمام، البلادر هون، لا في ناس عندهم البلادر برا الجسم. it may also lead to adenocarcinoma. تمام. فهي ال 3 types of bladder cancers. هلا we will go through each one. First we will go through villus adenoma أو adenocarcinoma. هي هيك شكلها. You need to memorize this picture. It's like a gland، يعني من اسمها adenocarcinoma. It's like a gland وهيك. ليش بتصير؟ إما urachal cyst أو exophytic bladder. لأنه قلنا البلادر is lined by urethelium، فمو معقول يصير عندنا adenocarcinoma في urethelium. وين بتصير؟ إما في اليوريكال cyst أو إذا البلادر أصلا abnormal وطالعة برا الجسم. فاكزيبتيك بلادر وريكال سيست كوزز ادينوكارسينوما. ممكن يجيب لك هاي الصوره ويقول لك in which disease it may happen، تختار يوريكال سيست او اكزيبتيك بلادر. ثاني نوع سكويمس سيل كارسينوما. هلا I don't want to go through سكويمس سيل كارسينوما how it looks، بس يعني هي فيها هذول الكيراتين بيرلز اللي هو هيك شكلهم. كيراتين بيرلز خلص فورا بتعرف سكويمس سيل كارسينوما. ليش بتصير؟ شيستوسوما هيماتوبيوم انفكشن. we'll go through it في المايكرو، بس I just want you to know انه شيستوسوما infection if it affected the bladder it will lead to squamous cell carcinoma. وهلا اهم كانسر في البلادر، قلنا البلادر is lined by transitional epithelium او urethelium. ف which most common cancer بالبلادر it's gonna be transitional cell carcinoma او urethelial carcinoma اللي هو اسمه papillary urethelial carcinoma، اللي هو كان carcinoma of the urethelium، ومن اسمه papillary. شو معنى papillary؟ يعني finger like projections، يعني هيك projections. اوكي، ف papillary urethelial carcinoma من الاسم papillary فيعني انها finger like projection. هون شوفوها finger like projection. urethelial carcinoma يعني neoplastic proliferation of the urethelium of the bladder. تمام. grossly يعني إذا شفناها قلنا it's papillary يعني finger like projections. حتلاقي في كثير أشياء projecting في البلادر وول. شوف كيف هو المفروض بلادر وول هيك أملس، بس لا طالع منه projections، هذول finger like projections لأنه اسمها papillary. on light microscopy as you can see here في عنا finger like projection هيك، أو هون finger like projection. ف that's papillary urothelial carcinoma. papillary نفسها معناها fibrovascular core lined by epithelium. يعني هون شوفوا كيف هون فاتح وبرا غامق، جوا هو fibrosis وبرا الابيثيليوم. حتى شوف هون فاتح جوا اللي هو fibrosis وبرا الابيثيليوم. فذات papillary urothelial carcinoma. ايش موست كومن ريسك فاكتور فور ذس؟ سموكينج. لازم تعرفوا الباقيين صراحه، ان اللي الدايز وسايكلوفوسفامايد، بس سموكينج از ذا موست كومن ريسك فاكتور for papillary urothelial carcinoma. ف for the last time we have three types of bladder cancer. فيلس ادينوما اللي هو ادينو كارسينوما بيصير باليوريكال سيست او اكزوفيتيك بلادر. سكويمس سيل كارسينوما بيصير بشيستوسوما. يوريثيريال ترانزيشنال سيل كارسينوما هذا الموست كومن اللي بيصير بالطبيعي اصلا. وموست كومن ريسك فاكتور از سموكينج. و it will cause papillary finger like projections. في يعني حيكون هيك في عندنا finger like projections. الصور لازم تنحفظ. ممكن يسألكم هذا ايش هو، لانه يعني if this is finger like projections then what is this. هذا atypical cells dysplasia whatever. بس بصراحة ما اتوقع يسألكم. البيكتشر is this. فذاتس بلادر كانسرز. طب لسه ما خلصنا البلادر ديزيزز. زمان قلت لكم انه هذا البلادر وول وفي اذا وي ميد مالتيبل انفكشنز حيصير عندنا شيء اسمه فون بران نستس، وبعدين هالفون بران نستس ممكن يدخلوا جوا ويصيروا بس هيك نستس. اوكي. ممكن اذا كمل وضل في انفلاميشن this developed to something called bladder cystitis cystica. يعني عندنا cystitis يعني inflammation of the bladder. cystica يعني في cysts جوا البلادر. شو هم هذول السيستس؟ هم الفون بران نستس. اوكي. فيعني if we have a bladder wall وسوينا له inflammation von Brun nest will be formed. It will be attached to the wall. كملنا الانفلاميشن it's gonna reach down and it's gonna be like this. كملنا الانفلاميشن حتصير زي السيست وبصير اسمها bladder cystitis cystica. ايش هي؟ chronic inflammation that cause formation of von Brun nests. طيب عندنا نوع تاني اسمه bladder cystitis cystica glandularis. هذا ستيج 4. يعني من شوي كان اول شيء انفلاميشن بيصير عندنا فون بران نست، بعدين بيصيروا جوا، بعدين بيصيروا انفليمد. طيب ايش رابع ستيج؟ جلاندولارز. بيطلع فيهم جلاندز من كثر الانفلاميشن. تمام. ف bladder cystitis cystica glandularis بيكون عندنا الفون براند نست. بس شوفوا شكلهم كيف صاروا جلاندز. تمام. او هون شوف كيف صار في لومن بالنص which is a gland. تمام. ف it's due to long standing irritation. فالسيست become glandular. بصير في glandular metaplasia وبصير عندنا bladder cystitis cystica. كمان if this keeps up we will have malakoplakia اللي هو هذول الأشياء. اوكي. it's called MG شو اسمه bodies أو malakoplakia. بصراحة I don't think this is very important بس يعني for the sake of completion I did put it. ف last time if we have a bladder وهذا اليوريثيليوم if we inflamed it we will have von Brun nest then it may go inside. Then if we continued we will have bladder cystitis cystica. هذا ال von Brun nest will be inflamed. بعدين if this keeps up it will become glandular. يعني في لومن في النص وجلاند ومدري شو. هذا bladder cystitis cystica glandularis. if this keeps up we will have malakoplakia اللي هم هاي الأشياء. تم. اللي هو بولز اي ليجن. يعني نشوف كيف هم شكلهم بولز اي. بس that's it for the bladder inflammation. Then we have hemorrhagic cystitis. يعني حيكون عندنا هاي البلادر وول حيكون inflamed ومليان نوتروفيلز وثك ومدري شو وكمان في دم. هلا من شوي ما كان في دم، كان نيوتروفيلز واميون سيلز ومدري شو. بس hemorrhagic cystitis فيه دم. فas you can see here في necrosis وفي دم ومدري شو. hemorrhagic cystitis I just want you to know شكله انه هيك inflamed وفيه دم و it's due to trauma لو حدا يعني انضربت البلادر تبعه. بس this is not very common. الكومن هو ساكلوفوسفامايد يوز. في دراج اسمه ساكلوفوسفامايد انتي كانسر ميديكيشن. chronic use of it will lead to hemorrhagic cystitis. بس that's what I want you to know for hemorrhagic cystitis. It's related to cyclophosphamide and this is how it looks. فيه دم. تمام. تمام. تشيك بوينت. خلصنا very big things. هلا داخلين على اشياء اسهل بروستيت يعني. What do you guys think؟ في عندكم أي أسئلة؟ أي شيء مو واضح؟ Shall I go faster slower؟ Tell me.
ممكن بس تعيد نقطة البلادر سيستيكا سيستاتيس سيستيكا واللي
أوكي.
بعد.
هاي البلادر هذا هو اليوريثيليوم. أوكي. البلادر وول. If we inflamed it اليورين ضل في obstruction في stone it will develop something called von Brun nest. هاي النست. أوكي. If we didn't resolve this the nest will go inside and become a ball. كرة. أوكي. بس ما انها inflamed it's just a ball. لو ضل الانفلاميشن هاي البول will be inflamed will be full of neutrophils وهيك. This is called bladder cystitis cystica اللي هو فون بران نستس في البلادر وفي inflammation active inflammation. If we kept it لليورين أو الobstruction أو الirritation هاي it will become not like a ball it will become glandular. يعني هيك في glands ومدري شو. هذا bladder cystitis cystica glandularis اللي هو stage 4. بس got it. يعني
تمام.
اول شيء on the epithelium، ثاني شيء بتصير جوا بس مو inflamed، ثالث شيء اللي هو الديزيز bladder cystitis cystica، رابع شيء بتصير glandular. بس كلير.
يس.
اوكي. now testicular diseases بصراحة يعني شوي heavy بس way easier than before. these are the testes as you can see here. هلا بس quick review. normally هذا اللي human body let's say. testes doesn't develop down، لا هم بيبدوا فوق and then they descend. When they descend by a layer of peritoneum called processus vaginalis. They descend and they reach السكروتم. اوكي. normally بعد ما الولد ينولد البروسيس فاجيناليس هذا get obliterated، يعني بيختفي. and the remnant of it is this tunica vaginalis. يعني التستيس is هاي testes it's surrounded by a layer. هذا اللاير اللي هو tunica vaginalis. من وين اجى؟ من processes vaginalis. اتس يعني فيه فلويد، اتس جاست بروتكشن ومدري شو. هاي التستيس سيمينيفرس تيوبيولز ومدري شو هون ابيديديمس وبس. تمام طيب. هاي النورمال تستيز هذول السيمينيفرس تيوبيولز، شايفينهم هيك تيوبيولز ميد اوف سبيرمز وسيرتولي سيلز وليدك سيلز ومدري شو. بس ذاتس فور ناو. اوكي. نبدا في اول ديزيز هيدروسيل. طيب هيدروسيل is collection of fluid في التونيكا فاجيناليس. شايفين هاي التونيكا فاجيناليس هي فيها فيو فلويد. لا بهيدروسيل بتكون فول اوف فلويد فبتصير هيك بيج لاير. طب ليش فيها كثير فلويد؟ مو انا قلت لكم بروسيس فاجيناليس هذا اللي نزل التستيز من فوق لتحت should get obliterated بس الولد انولد؟ لا. here in these patients it doesn't get obliterated، بضل موجود. فبضل في peritoneal fluid عم ينزل على الهيدروسيل، بضل till it's filled هيك وبتصير هيدروسيل. بتصير يعني يعني مو التستيز اللي منتفخه، مو انه في انفلاميشن او شيء، لا هي التستيز هون وقدامها في اللاير هاد بصير معبى فلويد فبتصير بهذا المنظر. اوكي. is it painful؟ لا it's painless. ف I want you to focus انه hydrocele cause painless swelling. هذا swelling ما انه inflammation of the testes، هو بس فلويد متجمع في الهيدروسيل. ف it causes painless swelling. ولو شغلنا عليه ضوء من ورا، يعني لو حطينا هيك تستيس شغلنا ضوء من ورا we can see انه fluid. That's what it means by transilluminate. ليش فينا نشوف؟ لانه مي it's just a fluid. لو شغلت ضوء على المي you can see it. ف it transilluminate. فهيدروسيل it's accumulation of fluid في التونيكا فاجيناليس. ليش؟ failure of filtration of process vaginalis. طب clinically هو بس fluid ف it's painless swelling وترانزلومينيت وما في تشينج ان سايز وين يو كف لانه خلص هو الفلويد موجود جوا. طيب هلا احنا قلنا انه البروسيس فاجيناليس didn't get obliterated، فالتستيز نزلت وصارت في مكانه وبعدين المفروض يختفي، ما اختفى فالفلويد ضل ينزل معها. طيب ممكن الانتستين تنزل معاه. اوكي. هون هاي complication of hydrocele، يعني people with hydrocele should get treated اصلا immediately عشان ما يصير عندهم indirect inguinal hernia اللي هو الانتستين تنزل بهذا البروسيس فاجيناليس. شفتوا كان الفلويد بس اللي عم ينزل من شوي، هلا لا هو كبير فنزلت الانتستين وصار عندنا indirect inguinal hernia، صار عندنا herniation of part of intestine. هلا بصير عندك ماس، والماس مو في التستيز، يعني مو بتطلع هيك، يعني بتطلع هون. اوكي. وت pressing on the testes بصير عندك infertility، بصير عندك كذا شيء. ف it must be يعني treated immediately. ويعني it's reducible، يعني لو ضغطت عليها بترجع لجوا، بس if you cuffed it will come back again. ف it's related to الستريس اللي بيصير فوق. if you cuff if you laugh if you cry if you strain it will go down. هلا ما بهمنا، المهم عندي هيدروسيل. هيدروسيل is accumulation of fluid in tunic vaginalis. this is how it looks. it's painless it's transluminate. ممكن يجيكم في الأوسبي واحد عنده painless swelling، بفرجيكم الصورة ايش هذا بتقولوا هيدروسيل. طب ايش complication؟ indirect inguinal hernia. طيب now second disease is varicocele. هلا التستيس هذول هم، وفي artery supplies them وفي vein that takes blood from them. الفينز اسمهم pampiniform plexus of testes. هذول هم. اوكي. it take the blood بالفينز وبيطلع and it reach inferior vena cava ومدري شو. خلصنا والحمد لله الدم وصل inferior vena cava وتم. إذا صار في obstruction هون فوق بالtesticular artery البلد will accumulate. if the blood accumulated it will cause varicocele اللي هو accumulation of blood in the veins. now ما صار عندنا مو مثل شوي it's just a fluid، لا هذا blood وفي الفينز. وشوفوا الفينز كيف هيك بيصيروا متشربكين يعني it become very هيك، يعني بيلتفوا حوالي بعض ف it become painful. اوكي. فvaricocele accumulation of blood مش fluid in the pumperiform plexus of veins causes venous dilation and congestion and it's very painful. طب ليش بتصير؟ اما obstruction فوق او الفالفز. شفتوا الفين فيه valve would allow blood to go in one direction. اذا الفالف not competent the blood will accumulate it will cause varicocele. طيب البرزنتيشن very painful لانه الارتريز والفينز خلاص تشربكوا في بعض فاتس very painful و it looks like a bag of worm. شوفوا كيف شكلهم هيك بصيروا الفين كانه worm. اوكي and it doesn't transaminate لانه المي when you shine light through it will transaminate. But blood if you do shine blood what's called light through it won't transaminate لأنه في RBCs white blood cells. It will block the light so it doesn't transaminate because it's made of blood and it may lead to infertility and atrophy. So I want you to know we have two diseases, hydrocele and varicocele. Hydrocele is just fluid so it does transaminate and it's painless. Look here, it's green because it's painless. Now varicocele, it's made of blood so it's painful and it doesn't transaminate because it's made of blood and looks like a bag of worm. And it's due to congestion of blood in the veins. Okay? Now we will go to like testicular diseases or cancers. Is everything clear so far?
Yes, everything's clear.
Okay. Now we have the normal testes. As we said here, it's made of seminiferous tubules or whatever. Some people, أنا قلت إنه testes should descend. Okay? It descends to the scrotum. If it didn't descend, it's called cryptorchidism, which is undescended testes. Testes will stay in the body, and the body temperature is way higher than the scrotal temperature. فالتستيز will be atrophied. فشوفوا كيف التستيز هون شكلهم مرتب. It's very organized. And in cryptorchidism, the testes will get atrophied. And look how here it's very unorganized all over the place and stuff. Atrophic testes, that's how it looks. The main risk factor to have atrophic testes is cryptorchidism or undescended testes. طيب, if this happened, it has a very high risk of becoming a cancer. Okay, we have so many cancers in testes, so please bear with me. First, the atrophied testes will not become cancer immediately. It will have dysplasia. And I guess you guys know by now, dysplasia is a cell that may become cancerous, but it's not cancerous at this point. So in atrophied testes, it may become intratubular germ cell neoplasia. So it's intratubular, as you can see here. It has the dysplasia or the tumor signs of a cell, which is high what's called nucleus to cytoplasm ratio. It's dysplastic, it has mitosis and whatever, but it doesn't invade the basement membrane. As you can see here, it's confined within the basement membrane, so it's still not tumor. يعني ما انها malignant tumor. It's not either benign because it may become tumor, but now it's still confined to the basement membrane, so it's not a tumor yet. It's intratubular germ cell neoplasia. اوكي. what are the features? nuclear enlargement يعني اي شيء كانسر. nuclear enlargement, hyperchromsia, fried egg appearance, كل هاد. And it's confined within the basement membrane. In light microscopy, it's dysplastic, but in the basement membrane. We can do a stain for it, and it will appear like a Christmas tree appearance. As you can see here, I didn't bold this thing because I think it's not important. Okay, so first we have normal testes here. If it's in the body, اللي هو cryptorchidism, it will be atrophied. If it stayed there, it will become neoplastic. First, it's going to become dysplastic, so it didn't evade the basement membrane. And then it will become cancer, and it will evade the basement membrane. Now, the testes itself, let's go back here. Testes itself, يعني one seminiferous tubule, is made of, here we have many sperms. جوا. Okay, in between we have something called Sertoli cells. يعني it's هيك مو in between يعني هم in between it. فاهمين؟ the sperms are inside and Sertoli cells are surrounding it, and here we have Leydig cells. Okay, so if we have a tumor, it's going to be either in the sperm, يعني هذول sperms are neoplastic and becoming a lot, which we call it germ cell tumor. germ cell لأنه الgerm cell هي السperm. But if we have a cancer related to the sperm, it's called germ cell tumor. It's neoplastic proliferation of the sperm or the germ cell. And we have other type of cancers اللي هم Leydig أو Sertoli cell هم اللي they are proliferating, not important, not high yield at all. We will focus on germ cell tumors. Testicular cancer, it might be from non-germ cell cells, which is Sertoli cells و Leydig cells مو مهم. And it might be from germ cells اللي هم sperms. They may يعني proliferate in a very crazy way to become so many sperms, which is called seminoma. يعني هذا الجيرم cell اللي هو السبرم might become a sperm الجيرم cell and might become other stuff اللي هم الامبريو اليولك ساك هدول الاشياء تبعت البريجننسي وال that period of life اللي هم embryological stuff syncytial trophoblast placenta and stuff. فالجيرم cell ممكن يصير سبيرم، ممكن يصير هاي الاشياء. اذا صار سبيرم وصار فيه كانسر، يعني السبيرمز هم اللي they are developing in a very rapid way, it's called seminoma. If it's become other stuff ليش هون ايوه if it's become other stuff اللي هم يولك ساك embryonal cells syncytial trophoblast site trophoblast, then it's called non-seminomatous germ cell tumor and it might be teratoma, embryonal carcinoma, yolk sac, choriocarcinoma, depends on what it come. يعني هون لو صارت syncytial trophoblast او trophoblast بتصير اسمها choriocarcinoma. لو صار yolk sac بصير yolk sac tumor. We'll talk about all of this, but I just want you to be clear with this. Testicular cancer, two types. Non-germ cell tumor اللي هم سيرتولي وليدك سيلز مو مهم. germ cell tumor اللي هم ممكن يصيروا sperms أو يصيروا أشياء البريجننسي والإمبريولوجي. If the germ cell become a sperm and then it become dysplastic, neoplastic, then it's seminoma. If it becomes something other than that, it's called non-seminomatous germ cell tumor. And it depends what it became. بنقول what type of cancer it is. Is this clear? Because now we'll go through each one and it's يعني heavy شوي. Is it clear?
Yes.
Okay, let's start with the first step, and this is the most common. This is probably what you will get asked for, صراحة. As we said, the germ cell may come as sperm and non-sperm. If it's a sperm and it becomes dysplastic, then it's seminoma. Seminoma, it's the most common germ cell tumor in the testes and due to malignant proliferation of germ cells, specifically the sperms. Okay, clinically it's painless mass, so it's just a mass painlessly. يعني هيك بالتستس بيكون في mass. People will feel like a mass وخلاص, no pain, no swelling, nothing. It's just a painless mass. Oh, by the way, all testicular cancers are painless mass except one of them. We'll go through it. But just think, testicular cancer, painless mass. Okay? Seminoma is a painless mass and it's the most common germ cell tumor. Grossly, it appear white, yellowish. يعني it's benign. It looks very benign أصلا. يعني شوفوا, it looks benign. White, yellowish, بس هيك mass, painless. But it's يعني dangerous لأنه it may metastasize. Grossly, as we said, white, yellowish mass, no necrosis, no hemorrhage. بس هيك white, yellow. Unlike microscopy, it's called nestic pattern. So here, this is normal. هذا النورمال او مو نورمال. This is the IGNS اللي هو intratubular dysplasia اللي هم لسه they are confined to the membrane. Here we have cancer and look here there are so many cells. So this means that the cancer evaded the basement membrane and went outside. Here it's dysplasia, here it's seminoma. Okay, it's cancer. That's how it looks. It looks as nests, يعني هيك nest وبراته مليونين ألف سل. And the appearance is called fried egg appearance. This is a very buzzword. You must know it. This is the appearance. Oh, this is the appearance. It's called fried egg appearance. You must know. Please, يعني know it by heart. Seminoma, most common. It's a painless mass. Grossly, it's just white or yellowish. Unlike microscopy, it's nesting pattern or fried egg appearance. ولابس I don't think it's important for seminoma but everything is low. في عندنا لاب بيتا اتش سي جي والفا فيتوبروتين هدول تبع البريجننسي they are low in the seminoma because we said germ cells can be sperms and non-sperms. النون-sperms هم الاشياء المهمين للبريجننسي. ف if it became a sperm وصار عندنا كانسر اللي هو seminoma, you expect the pregnancy hormones to be low لانه it's non-germ because it's not related to pregnancy. But these are the important thing in seminoma. I'm sure you will get a question about seminoma. Even I did step one I got a question about seminoma. I got it wrong. كان literally زي هذول الصور و I didn't answer it correctly. ف seminoma most common painless mass, white yellowish mass, nesting pattern, fried egg appearance. In lab everything is low. تم. Now second type we said germ cell might be sperm, non-sperm. Okay. let's focus now on the non-sperm. We agreed إنه non-sperm are stuff important in pregnancy. أول وحدة اسمها embryonal cell carcinoma. It's شو اسمها embryonal cell carcinoma malignant non-seminimatous germ cell tumor. We agreed إنه it's non-seminimatous. Okay? Clinically, it's very painful. Okay? عكس seminoma. It's very painful. It's the only one that it's painful. That's why it's a painful mass only. The only one that's painful. Grossly, لأنها painful. What do you expect it to look? Hemorrhagic, necrosis. It looks ugly. And in light microscopy, look, it looks very ugly. I can't tell أصلا what the hell is going on. Okay? People call it cord-like appearance. I can see a cord. I just see very يعني بشع هيك very awful appearance honestly. Lab wise it's high in everything. Okay, so I want you to focus إنه embryonal cell carcinoma is the worst. Okay, painful which is the worst. Hemorrhagic and necrosis يعني looks ugly. Light microscopy also looks ugly. Lab everything is high. But this is the worst cancer you might ever get. So cancers, germ cell, seminoma is fine, cute, lab is low, white, yellowish, whatever. And there is embryonal carcinoma, which is very vicious, painful, hemorrhagic, necrotic, awful appearance, high in all labs. Okay, that's embryonal cell carcinoma. That's what I want you to know. Okay, now we have Yolk sac tumor. I have mnemonic for this one. So Yolk sac tumor or endodermal sinus tumor. It's also malignant proliferation of non-seminomatous germ cell. We said germ cell is either seminoma or non-seminoma. So this one is non-seminoma. It's painless mass because only painful mass is embryonal, the vicious one. It affected children mainly. Grossly, it's just white or yellow mass. On light microscopy, it's Chiller-Duval bodies, which is this. Like, it's like an onion or glomerula. It looks like a glomerula. People call it glomerula like structure, but it's not important. The important name is Chiller-Duval body, or you know from هذا إجانا في الexam, I guess. So it's Chiller-Duval body. It's looked like this. And lab, it's just high alpha fetoprotein. So in pregnancy, we have beta HCG and alpha fetoprotein. In seminoma, both are low. In embryonal carcinoma, both are high. In Yolk sac tumor, only alpha is high. طب how will you guys memorize this? It's called the Yolk sac tumor. Sac is the mnemonic. S for Schiller-Duval bodies. So Yolk sac tumor, S because Yolk sac tumors has Schiller-Duval body. A is for high alpha fetoprotein. C because it affects the children only. So what I want you to know from Yolk sac tumor, that it's malignant non-seminomatous, it's painless because all of them are painless except embryonal is painful. Grossly, it's white yellow, and then the mnemonic sac. S is Schiller-Duval bodies اللي هم هيك دوائر. A is because it has high alpha fetoprotein. C is because it affects children. Okay, and this is also another image of Chiller-Duval body. فإن شاء الله Yolk sac tumor is clear. Then we have choriocarcinoma, and this is يعني بتعرفوا البلاسينتا is formed from two things: syncytial trophoblast and cytoplasm. Okay, if there is malignant proliferation of syncytial trophoblast and cytoplasm, then it's called choriocarcinoma. Okay, it's also non-seminomatous germ cell tumor. It's painless because all of them are painless except embryonal is painful. Grossly, it's very hemorrhagic, but it's not painful. It's just blood. It's هيك بس hemorrhage. Okay, and in light microscopy we have cytoplasm and syncytial trophoblast. Cytoplasm is the green one. It's single large cell, and syncytial trophoblast is the red one. It's like multiple cells. بس يعني بصراحة not that high yield, I would say. Just know that it's painless mass, looks hemorrhagic, and it has syncytial and cytoplasm in their structure. Okay. Last one in germ cell tumors, which is teratoma. هلا normally the germ cell will develop to either sperm أو الامbryo stuff. Okay. بس if it became like a human فيها tooth و hair follicle, cartilage, muscles, then that's called teratoma. Teratoma is germ cell tumor composed of tissue derived from two or more embryonic germ layers. يعني من شوي كان إما syncytio أو cyto أو Yolk sac stuff. بس في teratoma it became like a human. يعني شوفوا هون فيها cartilage. هون حتى فيها cartilage. Cartilage is for humans يعني بعد ما ينمو أو hair follicle أو هيك. فتيراتوما is germ cell tumor. الجيرم cell بدل ما it develop to a sperm أو embryonal stuff, it developed to like a human body. ففيها cartilage. والcartilage in histology it looks like eyes. فشوفوا هون كيف هيك it's like an eye. شوف هاي clearly an eye. That's teratoma. It's also a painless mass because all of them are painless except embryonal is painful and it has cartilage in it. Okay, so I will review them for one last time. Testicular cancer. It's either from germ cell or non-germ cell. Non-germ cell is سيرتوري أو ليدك ما بدي فيهم. هلا نيجي للgerm cell. Germ cells might be seminomatous, which is يعني إنه الgerm cell become a sperm and the sperm become cancer. This is seminomatous, and it's painless mass, painless. It has fried egg appearance وكثير عادي يعني. Then we have non-cinematus, and this is might be teratoma, which has cartilage and like a human body. It might be embryonal carcinoma, which is the ugly and هيك painful, hemorrhagic, necrotic, very ugly. You can't tell what's the structure. It has everything lab-wise high. And then we have Yolk sac, which is the mnemonic sac, which is C, Schiller Duval body, A, alpha fetoprotein high, C is children, and the last one is choriocarcinoma, which is the pregnancy stuff. اللي هما cytotrophoblast and cystotrophoblast. And by the way, I forgot to mention, it has high beta HCG. فيعني seminoma has low beta HCG and alpha fetoprotein. teratoma ما لها دخل في اللابس أصلا. What's called embryonal carcinoma has high of everything. Yolk sac, because it has sac A in it, it will have high alpha. Then what's left? We don't have one that has only high beta, which is choriocarcinoma. Choriocarcinoma is high beta. If nothing is high, then it's seminoma. If it's both high, it's embryonal. If it's alpha bus high, then Yolk sac, because sac A alpha fetoprotein. Then the last one, high beta, which is choriocarcinoma. Is everything clear?
في نمونك اللي هي SAC حقت يوكساك الاس ريبريزنت وشو؟
ايش؟ هذه حقت اليورك ساك. الاس شيلر دوفال بادي، الاس هذه هذا
أيوة.
الشكل. الاي الفا فيتو بروتين. السي تشيلدرن، انها افكتس تشيلدرن مينلي. بس كلير؟ اوكي. Now prostate diseases. Just a second. كم صلنا السيشن؟ اوكي والله طولنا شوي. Prostate diseases. Now this is the normal prostate. It has stroma here. Stroma فيها collagen, muscles, whatever. And here it has the columnar epithelium. That's the prostate. Also prostate is made of four zones. Transitional zone اللي بيمر فيها اليوريثرا. What's called peripheral zone اللي هي هيك من تحت. بس هذول اللي بيهموني، الباقيين وسنترال زون وانتيريور زون، بس المينلي ترانزيشن زون وبريفرال زون. اوكي طيب. also prostate made of two layers. glands اللي هو الابيثيليوم اللي هو هذا epithelium and glands. في ستروما اللي هو muscles وهيك. نبدأ بالديزيزز تبعت البروستات. oh wait it... just wanted to see the picture. Okay, first we have benign prostatic hyperplasia, which is benign proliferation of the prostatic glands. يعني الابيثيليوم الاستروما ما بصير فيها شيء. benign prostatic hyperplasia it's benign، ما هي كانسر، مو malignant. proliferation of prostate gland اللي هو الابيثيليوم. ممكن الاستروما ممكن الاستروما لا، doesn't matter. المهم انه في benign proliferation of prostate gland epithelium. honestly بستep 1 if you chose انه فيها استراما غلط، بس انا شفت عندكم محطوط انه ممكن يكون في استراما. it's mainly الجلاند، بس it might have stroma, doesn't matter. it's common in elderly الكبار. هيك واحد الكيس دائما بيكون واحد عمره 70 60 50 وفجأة صار عنده urinary symptoms. it affects الميديان لوب اللي هو transitional zone. clinically it causes urinary obstruction، لانه يعني البروستات as you can see here إذا صار هاي transitional zone it affects transitional zone. if it became very large it obstructs اليوريثرا فبصير عندهم urinary obstruction. on DRE it's enlarged rubbery non-tender prostate. هلا البروستات normally in DRE is rubbery. okay benign prostatic hyperplasia it's gonna be the same rubbery non-tender بس enlarged. that's it, enlarged. اوكي ما فيها شيء not tender، ما في nodules، rubbery بس enlarged. اوكي grossly it's enlarged smooth prostate. you can see median sulcus اللي هو هذا الخط اللي في النص. on light microscopy it's benign hyperplasia of the glands. ممكن الستروما ممكن لا. لاب وايز هاي بي اس اي هو يعني ماركر موجود في الجلاندز تبعت البروستيت. ف if you have benign proliferation of them you will have high PSA. treatment finasteride that's not very important للOSP. طيب ف it's benign. اوكي it doesn't become malignant اصلا. اوكي هلا في عندنا second type of يعني thing بالبروستيت. ممكن هذا الجلاندز الابيثيليوم become dysplastic doesn't invade بس dysplastic. هذا اسمه high grade prostatic intraepithelial neoplasia. It's intraepithelial. It didn't invade لسه بس it's dysplastic cell doesn't invade basement membrane. اوكي يعني as you can see here السيلز dysplastic ومليونين ألف سيل فوق بعض بس it didn't invade yet. It may become prostatic cancer. Prostatic cancer neoplastic proliferation of prostatic gland الجلاندز يعني مو الستروما. اوكي common in elderly. طبعا it affect posterior lobe يعني هون posterior lobe هي هاي اللي هي peripheral zone. اوكي it affect ال posterior lobe او ال peripheral zone. early ما في symptoms لانه يعني if you can see here it doesn't obstruct اليوريثرا الا لو كبرت كثير. ف early wise ما في symptoms. lately it may cause urinary obstruction بس it may metastasize للspine. ف it cause back pain and weight loss. اوكي ف prostate cancer it's in the peripheral zone. early it's asymptomatic. lately it may cause obstruction back pain لأنه it may metastasize للback و weight loss. On DRE it's hard irregular nodular asymmetric surface. يعني ممكن عندي صورة أيوة هون. طبعا احنا مثل ما اتفقنا انه benign prostatic hyperplasia بتصير بالترانزيشنال زون اللي هي في النص. الثاني بتصير posterior lobe اللي هو peripheral zone اللي هي هون. زي ما تشوفوا هون اتس هيك نوديول مو انه البروستيت كلها كبرت لا بس نوديول. ف if you did DRE it will be a hard irregular nodule بس. it may affect السلكس يعني السلكس هذا اللي بالنص ممكن يميل لأنه النوديول بس على اليمين مو مثل PPH it's the whole thing. ف you need to memorize in DRE it's hard irregular nodular. it may تمشي السلكس يعني بعيد عن النص. اوكي grossly hard irregular mass on light microscopy it has a specific thing اللي هو what's called Indian fill-in pattern اللي هو هذا. Uh, you need to memorize the buzzword صراحة and how it looks. Indian film pattern اللي هو من شوي كان البروستيت. لو شوفوا كم الكولومينار قديش thick و multiple columnar فوق بعض. بس in prostate cancer it become lined by only one layer. فشوفوا هذا الإنديان فيلم pattern يعني بس خطوط. حتى هون بس خط هيك خط خط خط. ف that's prostate cancer. في لها special stains for PSA and it will be positive. It may metastasize للspine and cause osteoplastic metastasis. يعني شوف هون السباين كيف في صار أبيض هون. فهذا osteoplastic metastasis. It cause back pain وهيك. That's what I want you to know for prostate cancer. Clear? Clear prostate cancer? Because I think you'll get a question at least in the MCQ.
Yes, clear.
Okay. Now we have acute prostatitis, which is the prostate and it's inflamed. بس acute prostatitis. Grossly, it will have purulent discharge اللي هو bacterial discharge وهيك due to infection most likely E. coli. أي شيء في ال UTI والرينال وهدول E. coli إلا specific cases will explain them بالمايكرو. بس acute prostatitis E. coli. Here we have purulent discharge. We can't do DRE to acute prostatitis. It's a question في الأوسبي. Which of the following is contraindicated في مين ما بنعملهم دي ار اي. الحل acute prostatitis. ليش؟ It's tender, it's very painful. فلو ضغطناها it's gonna be very painful of the patient. ف it's contraindicated. هلا still if we did it it's gonna be very painful and boggy prostate. Okay? ف that's what I want you to know for acute prostatitis. Very painful, purulent discharge. Most common cause is E. coli. DRE is contraindicated. Now let's go for kidney cancer. I think this is the last thing for pathology of renal. We may have some clinical stuff بس pathology I think آخر شيء الكانسرز. أول كانسر في الكدني is angiomyolipoma. هلا هذا benign. اوكي benign cancer. it's benign renal tumor. شوفوا الاسم angio يعني blood vessel. مايلو يعني muscles. لايبوما يعني lipids. فانجيومايولايبوما is blood vessels, muscles and lipids in the kidney. هيك they proliferate. It's benign بس يعني it's a mass made of blood vessels, muscles and lipids. Okay? When we do light microscopy, we'll see adipose tissue اللي هم هدول اللي هيك أبيض. We will see smooth muscles. We will see blood vessels. That's angiomyolipoma, a mass made of lipids, blood vessels, and smooth muscles. Okay? It's associated with a disease called tuberous sclerosis. يعني لو ما عرفتوا تميزوا الشكل، الكيس ممكن يكون حدا عنده renal issues, seizures, mental retardation. فهو في disease اسمه tuberous sclerosis بيعمل seizure, mental retardation, epilepsy, and angiomyolipoma. Okay? It's very easy. البيكتشر very high yield يعني ممكن تجيكم في الاختبار. Secondly, we have renal oncocytoma. هاي كمان benign. It's benign proliferation of intercalated cells of collecting duct. هلا انتم المفروض تعرفون ال collecting duct made of two cells. واحدة منهم is intercalated cells. إذا صار فيها كانسر بيصير عندنا renal oncocytoma. Benign proliferation of intercalated cells. طب ايش شكلها؟ عندها شكل اسمه central stellate scar اللي هو هذا. المفروض شكله زي النجمة بس I can't see the star بس يعني it's central stellate scar. Okay. On light microscopy, the intercalated cells are full of mitochondria. So if we increase their number, we will have so many mitochondria. والميتوكوندريا it appears eosinophilic. ف it will be eosinophilic cytoplasm. شوف كيف الصورة كثير زهرية. Because the intercalated cells اللي فيها renal oncocytoma فيهم mitochondria. If we increase the number of mitochondria, we will have eosinophilic cytoplasm. Clear? هذول benign. هلا عندنا renal cell carcinoma which is malignant. This is the most important cancer بالكدني. renal cell carcinoma neoplastic proliferation of tubular epithelium. شفتوا احنا الكدني فيها tubules, proximal convoluted, distal convoluted. If we had neoplastic proliferation of it, we will have renal cell carcinoma. Neoplastic proliferation of tubular epithelium. Most common upper lobe, not very important. Uh, we have two types. يعني هذا الابيثيليوم وقت بيصير له proliferation two types. إما clear cell carcinoma which looks like this. It's very clear. شوفوا كيف أبيض because it's full of adipose tissue. ف clear cells with clear cytoplasm due to high lipid content. في renal cell carcinoma ممكن تكون clear renal cell carcinoma. السيلز بيكون لونهم أبيض لأنه full of lipid. ممكن تكون papillary cell carcinoma. شو معنى papillary؟ finger like projection. شوفوا هون كيف في finger like projection, finger like projection. فيعني that's the other type. فيها سمومة بوديز اللي هو كالسيوم ستاف. بصراحة مو كثير important papillary من الكويشن about clear cell carcinoma. فرينال cell carcinoma neoplastic proliferation of tubular epithelium. most common type clear cell carcinoma بتطلع بيضة. ليش؟ full of lipid. طيب كلينيكلي هذا المهم لأنه السؤال بيجي هيك. هي بيجي رينال سيل كارسينوما بصير في ماس في الكدني إلى ترايد يعني 3 symptoms. flank pain يعني بين بالظهر, abdominal mass اللي هي الماس اللي على الكدني, وهيماتوريا. فإذا إجاك بيشنت عنده هيماتوريا, abdominal mass وفلانك بين, رينال سيل كارسينوما طوالي. أوكي. it may cause paraneoplastic syndrome مثل باراسيتميا وهايبركالسيميا بس يعني مو شغلتنا. كلير. I think يعني هذا definitely أحس في الاختبار. ف I hope it's clear. طيب هلا عندنا شيء ثاني اسمه transitional cell carcinoma. هلا الكدني itself البروكسيمال convoluted tubule وهدول made of كوبويد او كولومينار الله العليم. فبصير فيه اللي قلناه من شوي اللي هو renal cell carcinoma. بعدين في عندنا البلفس واليوريتر هدول they are lined by transitional cell. فممكن يصير في عندنا transitional cell carcinoma اللي هو neoplastic proliferation of transitional epithelium. مش الابيثيليوم تبع التيوبيولز, لا transitional epithelium اللي هو تبع اليوريتر, الرينال بلفس هدول. اوكي الكولكتنج هدول. اوكي. ف جروسلي ماس بالرينال بلفس. يعني شوفوا كدني, مو اذا جاب لكم صورة كدني تقولوا رينال سيل كارسينوما, لا لو برا اوكي رينال سيل كارسينوما, بس لو جوا في الرينال بلفس لا هذا ترانزيشن سيل كارسينوما لانه البلفس نفسه معمول من ترانزيشنال ابيثيليوم. و يعني اون مايكروسكوبي بس ترانزيشنال سيل هايبربليجيا بس اتس سمبل. بس هو هاي الصورة المهمة. ماس بالبلفس ترانزيشنال سيل كارسينوما. طيب خلصنا باثولوجي. اوكي I will go through clinical stuff very easy بعدين نشوف اذا عندكم question. casts. هلا وقت someone is urinating ممكن نعمل urinalysis اللي هو بنفحص اليورين وبنشوف what is the content. normally ما في content. اوكي يعني ما في casts. بس if we have this which is red blood cells casts يعني red blood cells متدمرين وصاروا في اليورين بس وشوفوا لونه احمر it's definitely red blood cells cast. This is hematuria. اوكي. ف if we have red blood cell cast في اليورين that's hematuria. ايش most common cause؟ نفرتك syndrome. هلا في other stuff مثل bladder cancer وهيك بس most common cause نفرتك syndrome. اوكي. ف red blood cells cast is hematuria. most commonly nephrotic syndrome. حولكم كيف السؤال اجى. someone عنده اعطاكم PSGN and then which of the following casts حيكون عنده، تختاروا هاي which is red blood cells cast. ثاني نوع من الكاست called muddy brown granular cast. هاي is the tubular epithelium. شفتوا الكدني وفي tubules، اذا دمرنا التيوبيولز البقايا تبعها حتنزل في اليورين. كيف حيكون شكله؟ مادي براون جرانيولار كاست. اوكي، اما هو الاسم اما مادي براون او جرانيولار يوم بيسالوا. طب وين بيصير ممكن يتدمر التوبولار ابيثيليوم؟ باكيوت توبولار نيكروسيس. اكيوت توبولار نيكروسيس قلنا بيصير اما اسكيميك او توكسيك، بيدمر التيوبيولز وبصير عندنا مادي براون جرانيولار كاست. لاست وان از وايت بلاد سيلز كاست. يعني في عندنا وايت بلاد سيلز باليورين، ايمت بتصير انفلاميشن. if you have inflammation حيصير عندنا نيتروفيلز حيطلعوا في اليورين and we will have white blood cells cast. Clear?
Yes.
Okay. Last thing في ال clinical kidney stones. Kidney stones is very important. Definitely we'll have an OSPE question about them, so we must know how they look like. أول ستون عندنا اسمها calcium oxalate stone. طب how it looks? A square with X. شوفوا كيف هيك X جوا. طب ليش X؟ لأنه اسمها calcium oxalate. كالسيوم اوكزاليت فيها حرف اكس فات لوك لايك ا سكوير وذ اكس. ففورا اذا شفته في الاختبار سكوير وفيه اكس كالسيوم اوكزاليت ستون بس طوالي. ثاني نوع ريكتانجلر بريزم، يعني مستطيل او مثل هيك يعني سبيكة ذهب I would call it صراحة. هيك اتس ريكتانجلر و people call it coffin lid اللي هو التابوت تبع الدفن. اوكي. إذا الشكل هيك rectangular then it's magnesium ammonium phosphate اللي هي ستروفايت ستون. هاي الستون اللي بتيجي هيك ستاج هورن ستون و it's very big block the kidney ومدري شو it's associated with protease. فإذا الشكل rectangular اللي مستطيل أو coffin lid then it's magnesium ammonium phosphate which is a strovite stone اللي هي مسؤول عنها protease. ثالث شيء هكساجونال اللي هو الشكل السداسي، هاي سيستين. اوكي. طريقة حفظ hexagonal is رقم 6. C is the third letter فيعني 3 6 دبل، فاهمين قصدي؟ فهكساجونال shape يعني لو شفنا ستون شكله سداسي سيستين ستون. ليش؟ C is the third letter ضرب 2 6. أنا هيك حافظه صراحة، ما أعرف إذا it's good mnemonic ولا لا، بس يعني. last thing is diamond or rhombus shape اللي هو الشكل اللي هيك. اوكي المعين I would call it او diamond people call it diamond. I don't know how this diamond but this is معين. المعين uric acid stone. اوكي so we have four type of stone. اذا الشكل فيه X calcium oxalate. اذا الشكل مستطيل magnesium ammonium phosphate اللي هي strovite stone. لو سداسي hexagonal cysteine لانه ثالث حرف وhexagonal 6. last thing is rhombus shape اللي هو معين أو diamond uric acid stone must be memorized by name. most common صراحة يسألوا اللي هي calcium oxalate. is it clear?
Yes.
okay. Now to diagnose kidney stone renal stones initially we do ultrasound. يعني أول فحص بنعمله إذا حدا إجى عنده kidney stone ultrasound. بس الديفينيتيف والجولد ستاندرد is non-contrast CT. ليش مو contrast؟ لأنه الستون appears white. If I put a contrast that looks like white the whole thing will be white. I can't see the stone. فwe'll do no contrast CT. We'll see everything black إلا الستone it will be white. If the question asking what's the initial test for renal stones ultrasound. What is the definitive non-contrast CT? Mainly they ask for the non-contrast CT mainly. خلصنا باثو وكلينيكال. I know I took time بس مايكرو راد كثير سريع حيكون أسهل بكثير. is everything clear?
في definitive للرينال ستون contrast with contrast صح؟
None. لا without contrast.
اوكي. ايه difference.
لانه الكونتراست لوك يعني الكونتراست لونه ابيض. لو حطينا ابيض والستون ابيض we will see the whole urinary tract ابيض. We can't see the stone. فit's non-contrast I'm sure.
تمام.
Okay, now we will go to microbiology. Basically هقول لكم ايش البكتيريا وايش الخصائص تبعها عشان تعرفوا تختاروا. وفي كم لاب تكنيك وهيك لازم تعرفوهم. We will explain them. هلا اول شيء we will know what's UTI. UTI urinary tract infection of the urinary tract. طب what is included in the urinary tract؟ في الكدني، اليوريتر، البلادر واليوريثرا. البلادر واليوريثرا is considered lower urinary tract. اليوريتر والكدني considered upper urinary tract. okay. if the infection is till the bladder we call it cystitis اللي هو inflammation of the bladder بس أو اليوريثرا معاها. That's lower urinary tract. إذا it affect the kidney we call it upper urinary tract. ف UTI inflammation of the urinary tract due to microbial infection يعني بكتيريا اللي سوت هذا الحكي. two types. اما lower UTI اللي هي cystitis او urethritis. طب ايش السيمتومز لو lower اللي هو البلادر بس؟ هو will have dysuria, urgency, suprapubic pain يعني البين بس هون عند البلادر. اوكي very يعني minimal I would say. تمام no fever ما في fever اوكي. بس if it's upper UTI اللي هو it's involved the kidney then it's called pyelonephritis. Pyelonephritis inflammation of the kidney. It will have flank pain. ليش flank pain؟ لأنه الكدني في الفلانك ف if we affected the kidney we'll have flank pain and fever اوكي plus minus اللي هو dysuria وurgency ومن هالحكي. ف UTI inflammation of the urinary tract. If it's lower the patient will not have fever. They will have dysuria, urgency, suprapubic pain. But if it's upper UTI we will have flank pain and fever. فإذا البيشنت عنده fever definitely pyelonephritis من دون تفكير اوكي. طب what are the causes of UTI? Most common is E. coli اوكي. يعني اذا بس السؤال حكى حدا عنده UTI definitely اختاروا E. coli. other stuff protease وهذول we will discuss them later. طيب to diagnose UTI we use ماكونكي كليد agar لانه هذا most sensitive للإي كولاي. يعني هذا بالضبط it doesn't grow except E. coli. فلانه we suspect انه it's mainly E. coli we must use this one ماكونكي كليد. لانه لو ما طلعت E. coli it's easy to know the rest. بس we need to rule out E. coli first. هذا سؤال كان في الأوسبي. which of the following is the agar that we use for UTI. لازم تختاروا ماكونكي كليد مو شكل كان كلام. لازم تختاروا ماكونكي كليد اوكي. طيب نبدأ. E. coli the most common cause of UTI. E. coli is gram negative ورودز يعني بس اللاين يعني it will look like هيك خط و pink لأنه gram negative. It's the most common cause of UTI even in sexually active women. هلا sexually active women they have a high chance of developing UTI من شيء اسمه staph saprophyticus. But that's not the most common cause. That's the second most common cause. The most common cause is still E. coli. فإن all cases most common cause of UTI E. coli إلا لو حكى لكم خصائص بكتيريا معينة special features of a bacteria that it's not E. coli. Now you won't choose E. coli. Otherwise it's E. coli. Even in sexually active women it's E. coli. So E. coli gram negative rods most common cause of UTI in all cases even sexual active women. Features it's gram negative rods so it will look like this. It's lactose fermenting, and only E. coli and Klebsiella from your lectures are lactose fermenting. طب what does lactose fermenting mean? That if you put it in makonki agar, which is this one that looks yellow, it will look pink. فيعني we put it in a yellow agar and it will appear pink in the agar. Why? Because it fermented lactose. Okay? ف E. coli is lactose fermenting. It appears as pink. It's easy to remember. E. coli is pink. And it's gram negative so it's pink and it's lactose fermenting so it will appear pink. I hope this is clear. It is also indole positive. There was a question in one of the batches انه حدا عنده UTI and the only clue was indole positive. Indole positive is E. coli. Now what most important virulence factor of UTI of E. coli قصدي E. coli يعني عنده مليونين ألف virulence factor. عنده capsule, fimbriae, many other things. But the most important one for UTI is P. fimbriae أو type 1 fimbriae because it allow it to adhere to urethra أو البلادر and cause UTI. Okay? Last important thing about E. coli. E. coli has something called extended spectrum beta-lactamases. When you treat a bacteria, you give a beta-lactam, which is penicillin, ceftriaxone, and whatever. E. coli has a beta-lactamase, which is an enzyme that destroy beta-lactams. That's why E. coli is resistant to methicillin. Okay, that's what I want you to know. E. coli is resistant to methicillin. Why? Because it has beta-lactamase. What is it called? Extended spectrum beta-lactamase. Okay. However, it's not resistant to vancomycin because vancomycin is not beta-lactam. Okay. Last time. E. coli is a gram-negative rod. It appears pink. It's most common cause of UTI in all people, even sexual active women. It is lactose fermenting, so it appears pink in makonki agar. Memorize this picture because this is what they refer to as E. coli in the exam. It's indole positive. It's has B. fimbriae as the most important virulence factor. And E. coli is resistant to methicillin, not vancomycin, methicillin, because it has something called extended spectrum beta-lactamase, which is an enzyme that destroys it, the beta-lactam. This is a beta-lactam test. When you put the bacteria with the beta-lactam, such as CAZ, I forgot what is it. It's like ceftriaxone or something. Um, it will not kill the bacteria. يعني, just to explain it well. Here, this is the drug. The white thing is the drug. The everything else is the bacteria. When we put it, the drug, it didn't kill so much bacteria. As you can see, the circle is very narrow because this bacteria is E. coli, and E. coli is resistant to ceftriaxone or beta-lactams mainly. But when we put it with clavulanic acid, which is another drug, which is not a beta-lactam, see the area of killing is very big. This proves that the bacteria is resistant to ceftriaxone, but not to clavulanic acid. So this test proved that E. coli is methicillin resistant. They will bring you a question about E. coli and then ask you which of the following picture proves that E. coli is resistant to methicillin. This is the picture, okay? Memorize it. We finished E. coli. Now everything else is easy. Protease is gram-negative rods, causes UTI, and causes trovide kidney stone. So in all cases, if they said UTI, you choose E. coli. But if they mention special features of like protease, such as trovide kidney stones, urease positive, swarming motility, then it's protease, okay? So protease is gram-negative rods. It will appear like this, by the way, because that's what gram-negative rods appear like. It causes UTI, it causes trovide kidney stones, this trovide kidney stone, and we agreed that it appear as a rectangle. Features, it's urease positive, you need to memorize that, and protease has swarming motility, which is this appearance. It's like swarming, you know. I hope you understood how, but it's swarming. And mentally, if you have water and you put one drop of water, you will have this swarming appearance. So this swarming motility, and it causes UTI and strovite stone. Okay. Now we have Staphylococcus saprophyticus. It's Staphylococcus. So it appears as cocci in clusters. Okay. Staphylococcus saprophyticus is gram positive, cocci in clusters. Okay. So you need to memorize the picture. It's the second most common cause of UTI in sexual active women. They will bring you a question about sexual active women and ask you which of the following is the cause of UTI. Don't choose Staph saprophyticus, choose E. coli. If there is no E. coli, you choose Staph saprophyticus. But E. coli is the first common cause. Second most common cause is Staph saprophyticus. Features is gram-positive cocci in clusters, so this is how it looks like. Catalase and whatever you don't need to know. I just put them for information. Lastly, we have Enterococcus. Enterococcus is gram-positive what's called cocci in chain. So it's like streptococcus, but it's not streptococcus. It's a special feature. It's enterococcus. It's a gram-positive cocci in chain. The only two things I want you to know about enterococcus, that it hydrolyzes iscolin in bile. What does that mean? That it looks like this. Just memorize this picture. It hydrolyzes iscolin in the presence of bile. So it appears black in a yellow agar, okay? So this agar was yellow in the beginning. When they put enterococcus, it became black, okay? So enterococcus appears black in the agar and it's vancomycin resistant. It's the only one that's vancomycin resistant. So E. coli is methicillin resistant. Enterococcus is vancomycin resistant, okay? So they will bring you a question and ask you which of the following is vancomycin resistant, and you need to choose this agar because that's enterococcus. I hope it's clear. Enterococcus, only two information. This is the agar of it. It appears black because it hydrolyzes iscolin in bile, and it's vancomycin resistant. Is everything clear? I would love to review them in one slide, but خلاص there is no time. We'll
Yes,
spend the whole time.
vancomycin resistant is Enterococcus, while
Yes.
the other one is the E. coli.
Yeah, methicillin E. coli and methicillin includes beta-lactams اللي هم penicillin, ceftriaxone, and enterococcus is vancomycin.
تمام.
Okay? Yeah, other stuff in micro. First we have schistosoma hematobium. Schistosoma is a parasite. Okay? It lives in fresh water. It mainly affects the people who swim in like a Nile or in the pool or wherever. So schistosoma is a parasite. Lives in the fresh water. affects swimmers mainly. The question will become like someone went and swim in a Nile or whatever, in a river, sorry. It lives in the snails as an intermediate host. They will give you a question. Which of the following is the intermediate host? And you will need to choose snails, okay, for schistosoma. Its infective stage called Cercaria. So it's either an egg like this or Cercaria, this is Cercaria, which is like the parasite itself. Okay, so this is also a question. Which of the following is the infective stage of schistosoma? Cercaria, and you need to choose this picture also. It leads to hemorrhagic cystitis, bladder wall calcification, bladder squamous cell carcinoma. We agreed previously that the cause of squamous cell carcinoma in the bladder is infection with schistosoma. So schistosoma affects which organ? That's a question. Bladder. Okay, you need to choose the bladder. Why? Schistosoma affect the bladder and causes hemorrhagic cystitis, bladder wall, bladder squamous cell carcinoma. There are three types of schistosoma. The only one that affect the bladder is hematobium. يعني memorize the name. Schistosoma hematobium is the one that affect the bladder. What are its features? It's oval shaped. يعني شكل بيضاوي, as you can see, it's like an egg. And it has a terminal spine. So the spine is at the end because other types has spine here or it doesn't have a spine. But no, schistosoma hematobium has a spine in the end. Just imagine it like the spine pierce the bladder and cause it to be hemorrhagic. Okay, which is hemorrhagic cystitis. One important note, very random information, but it was asked. If someone has schistosoma and they have the egg in their bladder, if they did exercise, the excretion of the egg will increase in the urine. يعني if they have the egg in the bladder and they went and exercised, the egg will appear in the urine يعني in a very high amount. Okay? So for the last time, schistosoma hematobium is a parasite that lives in the water. It also lives in the snails and intermediate host. It has two forms, egg or cercaria. This is the shape of cercaria. You need to memorize the picture, and this is the shape of the egg. For the egg, it's oval shaped and has terminal spine because the terminal spine pierces the bladder and causes it to become hemorrhagic cystitis. It also causes bladder wall calcification and bladder walls cell carcinoma. If the woman went and exercised while she has schistosoma, the excretion of the eggs will increase in the urine. Okay, that's it for schistosoma. Now we have a test. Okay, urine prostate secretion collection. يعني we want to do urinalysis. We want to collect the urine from the patient. There are some steps that we need to follow. At first, when someone urinates, it has three phases. Sorry, initial, middle, and end. In the initial, we will only secrete the urine that are in the penis or in the urethra itself. يعني there is nothing from the bladder. If someone has infection in the bladder, you can't collect urine from the initial one only because this will show the collection in the urethra only. So we call it VB1. VB1 is only for the urethra. Okay? Then we have VB2. VB2 is for the bladder only, which is midstream urine. Okay, so first we have initial stream urine, which is the urethra only. Then we have midstream urine, which is the bladder only. يعني بعد ما خلصنا اليورين اللي في اليوريثرا, now we reach the urine in the bladder. Then we have something called EBS. If we did DRE, we can do something called prostate massage. If we massage the prostate, it will secrete its secretions, and now the secretions is here. These secretions is called EBS. It's impossible to collect EBS alone because there will be urine here or urine في البلادر, it will definitely pass by. I don't want you to know EBS as a thing. But I want you to know that EBS refers to prostate secretion. Now, VB3 is prostate secretion and urine. يعني we do digital rectal exam, we massage the prostate secretion is here, then the person urinates, it will have both urine of the bladder and the prostate, and that's called VB3. So if I ask you, someone has urethritis, which is inflammation of the urethra, which collection we should do? We should do VB1 because VB1 is for urethra. Now, if someone has bladder inflammation, which is cystitis, which one we should do? VB2. Okay. If someone has prostate inflammation, which collection we should do? Not prostate inflammation. If we want to collect prostate secretions, which collection we should do? VB3. Because VB3 is the one that has prostate secretions. Okay. تم. طيب. Last question. If someone has acute prostatitis, يعني inflammation of the prostate, Which of the following is contraindicated? The one that is contraindicated is definitely EBS and VB3. ليش? Because if someone has acute prostatitis, we can't do DRE. DRE is contraindicated. And this requires us to do DRE. In acute prostatitis patient, which of the following is contraindicated? EBS and VB3. Okay? So this is it. Easy? Clear?
Yes.
Okay, now, as I said, ABS and VB3 are contraindicated in acute prostatitis. Now questions, very random questions, honestly. Which of the following confirms the diagnosis of chronic prostatitis؟ يعني حدا عنده chronic prostatitis, inflammation of the prostate, بس مش acute, مش ال painful one. خلاص, chronic, it's not painful anymore, it's just inflamed. VB1 have prostatic secretion, يعني this one has prostatic secretion. This is impossible. VB1 is penile secretions, it's impossible to be A. Pus in the urine in midstream, يعني في pus in this one. No way, because this is bladder inflammation. Any bacterial organism detected before prostate massage. This is also not related. If we see D, EBS is higher than VB1 and VB2. يعني in EBS is the prostate secretion, okay? So in VB3 has this one, and EBS. If EBS is very high, then we have a high prostatic secretions. So this confirms chronic prostatitis. Is it clear?
Yes.
اوكي. او دام ده الوضوح. اوكي صار كويس. اوكي. in Mir and STEMI quantitative localization culture test اللي هو اللي شرحناه من شوي. Which of the following would be used to culture urine from bladder? We agreed انه VB1 is urethra. 2 is bladder, so we choose the second tube. بس I know it's very stupid question, بس يعني it came and you guys must memorize إنه VB1 is urethra, which is A. VB2 is bladder, which is B. C is EBA. خلاص فاهمين؟ بس هم they will only ask about B or A anyway. طيب B. Which of the following is the right container for urine collection? This one, okay? Just memorization. This is the urine collection container. بس just memorize الشكل يعني. خلصنا micro. Is everything clear? By the way, this covers every single question in the previous exams. That's why I have so many random questions. Is it clear?
Yes.
Okay, just realized إنه الكاميرا ضايرة هيك مدري كيف. Okay. طيب, now we will do radiology. And radiology is kind of tough, but it's just pictures. I just want you to know إنه هاي picture refers to this وهاي picture refers to that. ما في شرح diseases, ما في أي شيء. We already covered all the diseases almost أصلا. Let's start. بس دقيقة أطيرها هاي. Okay, first we have what we already discussed, which is kidney stones. Kidney stones is a stone in the kidney or pelvis, whatever. Initial, we do ultrasound. How does it look like in ultrasound? Hyper echoic, hyper echoic area with shadowing behind it. أنا ما لازم أكتب عليها عشان تقدروا تشوفوها. شوفوا هون كيف دقيقة. هيك في dense area, هذا الأبيض very dense, hyper echoic we call it. Then there is shadowing behind it. This is a stone. دائما هذا الشكل شكل stone. White thing behind it is a shadow. That's kidney stone. Okay? This is kidney stone in ultrasound. We call it echoic, hyper echoic. Okay? Stone dense, بعدين وراها shadow. Okay? However, the gold standard we agreed is non-contrast CT. It will appear as a white thing. بس خلصت. That's why we don't do contrast, because if we did contrast, everything will appear white. We want the stone only to appear, so it's non-contrast CT. Then we have hydronephrosis. High kidney, this pelvis, we obstructed it, then the urine accumulated and everything dilated. That's hydronephrosis. And as you can see here, everything is dilated من هدول التيوبز والبلفس وهيك dilated, hydronephrosis. Memorize the pictures, guys. هاي الصورة bladder calcification. شوفوا كيف البون looks white. However, the bladder shouldn't look white. However, here it's surrounded by white. فالبladder is calcified. What caused calcification? Schistosoma. We agree. Schistosoma hematobium causes bladder calcification. Then we have pyelonephritis. That is very important. It came so many times. Pyelonephritis, we agreed, it's inflammation of the kidney. How does it appear? As striation. يعني رمادي أبيض رمادي أبيض. It's like a zebra. Black, white, black, white, or gray, white, gray, white. Look here. Gray, white, gray, white. Light black, light black. You see? It's striations. Okay, so acute pyelonephritis on CT scan, it appears as striations. Here it appears also striations. It's not very clear, honestly. But I wanted to include the ultrasound. So here white, here black, here white, here black. طيب. Pyelonephritis, which is inflammation of the kidney, it might be acute, which is this striation, and it might be emphysematous, which is like emphysema. You know what's emphysema? اللي هو accumulation of air in the lung, okay? In the alveoli, it just accumulates. Emphysematous pyelonephritis, you will have air in the kidney. You see here, we have black, white, and then there is black, serious black dots. هذول air. Or here, this is air. So this is emphysematous pyelonephritis. Emphysematous pyelonephritis is striations and air. So striations, which is pyelonephritis, and then there is emphysema, which is air in the kidney. Okay? Clear, I guess. Then we have xanthogrammatous pyelonephritis. So this one, we have pyelonephritis, the striations, but the striations are not like lines, it's dots. It's called beer bow sign. It's like how the bear foot looks like, as you can see here. So it's called xanthogrammatous pyelonephritis. Okay, so pyelonephritis, if it's just the striations, it's acute pyelonephritis. If it has black dots, this is emphysematous pyelonephritis. If it has the bear paw signs, which is the striations are like circles, this is xanthogrammatous pyelonephritis. Now there is abscess. The kidney itself might develop an abscess above it. How to differentiate that from tumor? The case in tumor will be weight loss, flank pain. However, in renal abscess, they will have fever because it's an abscess, it's an inflammation or infection. Renal abscess, it's like a mass above the kidney, it's full of pus and stuff. However, there is also perinephric abscess. So this is the kidney and it's surrounded by a capsule. Perinephric abscess is like the abscess is between the kidney and the capsule. This is how it looks like. It's not very high yield, honestly. This one is the high yield one. But yeah, so you need to know. But focus on renal abscess. I saw it multiple times in the questions. Then we have autosomal dominant polycystic kidney disease. We already discussed this. Multiple cysts in kidney and liver. So here is the kidney, here is the kidney, here is the liver. We have cysts in the liver, cysts in the kidney. So this is autosomal dominant polycystic kidney disease. Then we have medullary sponge kidney disease, which is multiple.
Sorry.
Okay. Then we have medullary sponge kidney disease. We discussed in medullary sponge kidney disease is multiple cysts in the medulla that looks like a sponge. See here and see here. This is not very definitive. This is a good picture of it. This is medullary sponge kidney disease. Multiple cysts in medulla only. Okay. Then we have the Bosniak classification. I won't go through it again. Just put it in radiology if people wanted to review radiology only without passing through the whole thing. If you are watching this video and watching radiology only, please go to the micro part or patho part. I explained this at simple renal cyst. Then we have some renal anomalies. Let's explain how the kidney develop. At the beginning, this is the human body. Here we have the thoracic area, اللي هو الصدر, like lungs and stuff. Here we have abdomen area, which is stomach, intestine, and here we have pelvic area. The kidney starts here. Okay, and then it ascends to the abdominal area. Okay, kidney on both sides ascend to the abdominal area. If the kidney ascends so much and reach the thoracic area, that's called thoracic kidney. See, here is the kidney at the level of the liver. However, we have a kidney at the level of the lung. That's thoracic kidney. We also have something called pelvic kidney. Pelvic kidney is the kidney didn't ascend to the abdomen. So we have a kidney near the bladder. So normally the kidney should be at the level of the liver. If it's above, that's thoracic. If it's at the level of the bladder, that's pelvic kidney. Okay? Then the kidney may fuse. If they fused at one side, like here, both of them, left and right, are on the left side only. That's called cross-diffused kidney. Okay? If only the inferior lobe of the kidney is fused, that's called horseshoe kidney. So here we have two kidneys. If both kidneys appear to be on the same side, fused, that's cross-diffused. Cross-diffused. If both fuse just from the inferior lobe, so it's like crescent shape, that's horseshoe kidney. Okay? I think clear. Horseshoe kidney is important clinically, so horseshoe kidney is congenital fusion of the inferior lobes, not both kidneys fused, just the inferior lobes. So it looks like a crescent shape. Okay? That's the horseshoe kidney. When they ascend together, they will get blocked because if these are here in the pelvic area and they ascend, if they are separated, they will ascend and خلاص reach their places. But if they are fused, they will get blocked by the first thing that come in their way, which is inferior mesenteric artery, very important for your MCQ. So horseshoe kidney, fusion of the inferior lobes. When they ascend, they get blocked by the first thing that will appear in their like way, which is inferior mesenteric artery. So they will be like this. Okay, they will not reach the level of the liver. There is high risk of infections, but most importantly, canaliculi, which is stones. Okay, so horseshoe kidney. Someone has horseshoe kidney. They will develop mostly likely what? Stones, which is canaliculi. If it's not in the choices, infection. Okay, clear? Right. Now we have normally a kidney with ureter, another kidney with ureter, and reach the bladder. Okay, we have something called double ureter. So someone has two ureters on the same side. Okay, not two kidneys, just two ureters. So one kidney is one kidney receiving two ureters. This is important. Yani this is a question. Okay, and then they may ask you a follow-up question. What's complication that may happen because of this? Recurrent UTI and hydronephrosis. Because these ureters, two, they are very weak. Because it's like one separated to two. So it's very weak. It causes obstruction. So it will lead to hydronephrosis. And obstruction of urine will lead to inflammation, which is recurrent UTI. Another thing, we have the kidney here and the pelvis. And if we have a stone here blocking, we will have hydronephrosis. So this is hydronephrosis. Why? Because there is obstruction of the uretropelvic junction, which is the junction between the ureter and the what's called the kidney. Okay, clear. Now we have renal angiomyolipoma. We explained renal angiomyolipoma is a thing that happened with a disease called tuberous sclerosis, which people have seizures, epilepsy, mental retardation, and they will develop renal angiomyolipoma, which is benign tumor that's full of angio, which is vessels, myo, which is muscles, lipoma, which is lipids. Okay, so renal angiomyolipoma, it's a benign tumor of vessels, muscles, and lipids. How it will look like? Mixture of everything. A mass that's full of everything here. Also, one important thing, fat and air and fats appear black in CT scan. So in emphysematous, emphysematous pyelonephritis, if you saw black dots in the kidney, you chose emphysematous pyelonephritis. However, if you saw also a black dot in the kidney, you will also choose angiomyolipoma. So if I brought you this picture and ask you, is this angiomyolipoma or emphysematous pyelonephritis? You will use the case to differentiate. If the person have fever and UTI stuff, then it's emphysematous pyelonephritis. If the patient have seizure and like tubular sclerosis stuff, then it's angiomyolipoma. We skipped a lot. Is everything clear? Because we are almost there, almost there. Clear?
Yes.
Okay. Now renal trauma. So I have a kidney and I struck someone from behind and stabbed him and now he have bleeding. Normally this is the kidney and is surrounded by a capsule. Okay. So we have 5 grades of renal trauma bleeding. First, if the bleeding is just confined to the capsule. So see, the bleeding didn't reach the kidney itself. It's between the kidney and its capsule. So here, the bleeding is here. It didn't affect the kidney. It's behind the kidney. So it's between the kidney and the capsule. That's grade 1. Grade 1 is subcapsular bleeding or subcapsular hematoma. Grade 2, if the bleeding reached the kidney, but barely, so it's below 1 centimeter into the cortex. That's grade 2. Grade 3, if it's more than 1 centimeter into the cortex. Okay, so if it's subcapsular between the kidney and the capsule, that's grade 1. If it started to reach below 100 centimeter into the cortex, that's grade 2. If it's reached more than 100 centimeter into the cortex, that's grade 3. If it's reached the medulla or collecting system, which is يعني it's here in the middle يعني خلاص صارت في نص الكدني, that's grade 4. It may also reach the renal artery. So يعني it reached the middle and the vessels and everything. That's grade 4. Grade 5 is shattered kidney. Kidney is completely destroyed behind, فوق, تحت, يمين, يسار, it's destroyed. So that's very important. You will definitely have a question about this. Renal trauma, grade 1, subcapsular hematoma. So it's between the kidney and the capsule, okay? Grade 2, it started to reach the kidney, so it's below 1 centimeter into the cortex. Grade 3, more than 1 centimeter into the cortex. Grade 4, it reached the medulla, which is middle of the kidney, and the collecting ducts, arteries, and whatever. Grade 5, shattered kidney, completely destroyed, okay? I hope it's clear. Now we have important pictures also. This is renal parenchymal tumor. So it's tumor of the kidney itself. So as you can see here, the kidney itself is dilated. Here we have renal stone. I think it's clear at this point what is renal stone. Here we have transitional urothelial cell carcinoma. So we said that the kidney is made of يعني cuboidal or columnar epithelium. So the cancer of the kidney اللي هو renal cell carcinoma is gonna cause this renal parenchymal tumor. It's enlargement of the kidney itself. However, transitional cell carcinoma, it affects the renal pelvis or the ureter or the bladder, but it's mainly the pelvis and ureter. So here we will have enlarged ureter with obstruction من كثر ما انه enlarged يعني. Okay. Here also we have obstruction or hydronephrosis. So here the what is it? The ureter is obstructed, and so we have hydronephrosis. You know, the pelvis is enlarged. For now, I want to ask you how to differentiate between uh, transitional cell carcinoma or obstruction hydronephrosis, because both will cause the pelvis to be يعني enlarged. You look to the ureter itself. If the ureter is very narrowed, that's obstruction. As you can see here, the ureter is very enlarged compared to here, that's transitional cell carcinoma, because transitional cell carcinoma will cause a mass in the ureter. So the ureter will be enlarged and full. That's why it's obstructed. In an obstruction is because of a stone or something, so the ureter is narrow. Clear? This is
Yes.
very important. Okay. Now we have like the testes, and we did ultrasound. Both of them showed black areas. If we did ultrasound Doppler and it showed nothing, يعني ما في أزرق وأحمر, it shows no blood vessels and stuff, that's testicular abscess because there is no blood movement. If it showed Doppler showed the blue and red, that's blood movement. Clear? If we did ultrasound of the testes, if no blood movement, that's an abscess. If there is blood movement, that's a tumor. Bas. It's very easy. This is also something called Wilms tumor. Wilms tumor is a tumor of the kidney that caused the kidney to be massively enlarged. يعني the kidney is way larger حتى than the liver. So as you can see here, the kidney is way, way larger than the liver. That's Wilms tumor. Just memorize the picture. The disease, I don't think it's important for the OSPE. Just memorize the pictures. If the kidney is massively enlarged, that's Wilms tumor. Is everything clear?
Yes.
Okay, now we finished everything that I think is important for OSPE and came previously and everything. But unfortunately, you guys, your rad doctor in radiology changed to a new doctor, so he may bring some new stuff. So I included extra stuff from his lectures that usually never was asked before. But now it's a new doctor, who knows what will happen. So it's just 7 slides, yani 7 diseases. I want you to know their radiology. First is this. This is the same as renal trauma. You remember renal trauma grade 1, 2, 3, 4, and there is bleeding. This is the same. This is renal trauma and there is bleeding. But this is, oh, I forgot to write. This is renal infarction. Okay, this is the picture of renal infarction or renal hematoma, bleeding. Okay, so just memorize this picture. It's the same as grade 1, 2, 3, 4, bleeding above the kidney. That's renal trauma, renal infarction, renal bleeding. Okay, that's first picture. تاني شيء is renal artery stenosis. As you can see, this is the aorta. It gives renal artery on both sides, and as you can see here, the renal artery is blocked. This is called renal artery stenosis. It will also cause infarction of the kidney, as we see here. This is infarction, we said, right? So this is also infarction because the renal artery stenosis block the blood to the kidney, and this will cause infarction. Third thing, we have this picture. So here, this is the artery, and give the renal artery on the right and on the left. As you can see, on the right, we have two renal artery. On the left, we have renal artery stenosis. And so we have necrosis of the kidney. Clear? I just want you to know because they may bring it as MSQ. What's happening on the right? What's happening on the left? On the right, we have two renal arteries. On the left, we have renal artery stenosis. Here, as you can see, the renal artery is not stenosed. ما في يعني stenosis is like this. There is the artery and there is something blocking it. But here, there is nothing blocking it. It's just very irregular and weird. That's fibromuscular dysplasia. It's dysplastic renal artery. It's very weird, irregular and stuff. So just to choose fibromuscular dysplasia, this came. Here we have the renal artery and it suddenly have this. What's this? Aneurysm. So this is aneurysm of the right renal artery. Easy. Here we have the bladder, and normally the bladder has a very thin wall. However, if the bladder have a very thick wall, as you can see here, that's inflammation. Inflammation causes thickening of the bladder. So ischemic cystitis is thickening of the urinary bladder wall, okay? And it has edema. That's why it's very thickened. So normally the urinary bladder is very thin. However, if it's become very thick, as you can see here, it's going to become full of fluid. That's cystitis, okay? Inflammation of the bladder. There is something called Merck syndrome, MRKH, I call it Merck. I'm not sure if that's important. I saw it in his slides. Merck syndrome is absence of the uterus and the kidney. So you will have a patient without a uterus or a kidney. So as you can see here, this is the liver, this is the left kidney, and there is no right kidney. So that's Merck syndrome. There is no right kidney. And also they will not have a uterus. Normally we have the fallopian tubes and they open to the uterus. This patient doesn't have a uterus. So Merck syndrome have two features. No uterus, no kidney. And one of the kidney will be missing. So if you have a patient without a kidney or without a uterus, that's Merck syndrome or MRKH. Okay? Is everything clear?
Yes.
Okay, guys, now we will go through the past papers, inshallah, very quickly because I already covered everything. By the way, shout out to your amazing lab committee heads, Khalid Wurim. يعني their stuff والfiles وهيك help me in making this OSPE review, like make it so easy. فما شاء الله على شغلهم. طيب يلا, let's start. First, microbiology. Which of the following indicates ESBL production? What is ESBL? ESBL is extended spectrum beta-lactamase. I told you, extended spectrum beta-lactamase is the thing for E. coli. Which of the following is the picture for that? It's this one, which shows when we put ceftriaxone or whatever beta-lactam here, it doesn't do anything. But when we add something that is not a beta-lactam, it kills. So we have resistance against beta-lactams. So answer is A. Which of the following most frequent cause of UTI in sexual active females? Most common cause of UTI in all people, even sexually active females, is E. coli. I told you this in the lecture. This one is saprophyticus, which is second most common. So please, please, please choose E. coli. Someone presenting with hematuria after swimming in lake. Which of the following is the cause? We said hematuria. After swimming is schistosoma hematobium. What's the shape? Oval with terminal spine, because the spine will pierce the bladder and cause hematuria. So it must be terminal. Don't get confused with this. It must be terminal at the end of the oval shape. So it's A. Which of the following is resistant to methicillin? We said methicillin resistance is E. coli. Which one is E. coli? This one, which is lactose fermenting. We said that. E. coli, E. coli, definitely E. coli. An organism is known to be resistant to vancomycin. Vancomycin is, we said, vancomycin is Enterococcus. Which one is Enterococcus? Is this one, definitely A. Intermediate host for schistosoma. We said schistosoma is for swimmers and it lives in either pool with water or intermediate host is snails. طيب, which of the following right container for urine collection? It's definitely this one. We memorized that in the lecture. طيب, 27-year-old female recently married has UTI. What's the most likely cause? Most common cause of UTI in all people, even sexually active women, is E. coli. So it's B. Which of the following responsible for the misuse of cephalosporins in Enterococcus? Okay, يعني which of the following is Enterococcus? Okay, لا تلخبطوا. It's Enterococcus, this one. خلاص, A, definitely. In that experiment, which of the following used for bladder? We said VB1 for urethra, 2 for bladder. So 2 is B, bladder. Dysuria, increase urine frequency, urgency, يعني urinary symptoms, and flank pain. So this patient have cystitis. Culture reveals urease positive. The only one that was urease positive was protease. Protease, the one that has swarming motility. So we choose this one. Swarming motility. Why? Because it has urease. لا تقولوا لي E. coli most common. خلص, he said urease positive. E. coli is not urease positive, so it's protease. Sexually active female, increased frequency, urgency, hematuria. She is not pregnant, no history of UTI. What's the most likely causative agent behind this? Come on, patient. What's most common cause of UTI in all people, even sexually active women? E. coli, B, definitely. Okay. Which of the following organ? Schistosoma hematobium infect. قلنا schistosoma hematobium cause squamous cell carcinoma of bladder, hemorrhagic cystitis, calcification of the bladder. So it affects what? The bladder, definitely. 26-year-old woman taking thiazide for hypertension have hyperuricemia. Hyperuricemia يعني high uric acid. Which of the following is uric acid? قلنا uric acid اللي شكلهم معين, diamond, rhombus. So it's A. Which one is associated with enhanced excretion of schistosoma eggs? We said schistosoma eggs in a woman who exercise a lot, it will increase its excretion in urine. We said in the lecture, so that's the answer. أنا منزل تحت بسرعة. لا. طيب, a urine culture grows E. coli. What is the mechanism of resistance? How is E. coli resistant to methicillin? قلنا ESBL. So ESBL means that they have an enzyme called beta-lactamase that destroy methicillin. That's why how it's resistant. Mention the name of the virulence factor of E. coli. We said in the lecture it's Fimbriae. So it's gonna be Fimbriae. What are يعني which agar is strovite stone? We said strovite stone is protease. Protease is swarming motility, which is this one. So it's B. A group of children develops itchy rash after swimming. يعني حدا راح swimming وبعدين صار عنده راش ويعني صار عندهم اللي هو شيستوسوما stuff. ايش قلنا الانفكتيف stage. They are asking what's infective stage. Cercaria. We explained this. The most common finding seen in urine of nephritic syndrome. Nephritic. قلنا nephritic hematuria. So they will have RBC cast. What is RBC cast? This one. Red one. High granular. So this is ATN. Cuticular necrosis. This one is white blood cells. This one, Allahu Alam. There is nothing here. Someone went to the Nile and he have hematuria. يعني سبح. He is someone who swam and have hematuria, bladder calcification. So they have schistosoma. What is the infection? يعني stage cercaria. This one. Schistosoma hematobium. Memorize the picture, please. لأنه الصور الثاني, the other picture was very weird in the exam. So just memorize this one. Which one of the following crystal is seen on urinalysis on patient with protease? We said protease is strovite stone. Strovite stone is rectangle. So it's this one, B. Which diagnosed modality contraindicated in acute prostatitis? We said in acute prostatitis, we can't do DRE because it's very painful for the patient. So it's digital rectal exam. Which one of the following confirms the diagnosis of chronic prostatitis? So someone has prostatitis and يعني there are high prostate excretions. Which one of the following confirms it? Is VB1 having prostatic secretions? No, because VB1 أصلا is for urethra stuff and هيك. But doesn't have prostatic secretions حتى لو we have chronic prostatitis. So this is wrong. Pus in urine in VB2. VB2 is for the bladder. So if we have a pus, we have cystitis. So no. Any bacterial organism before prostate massage? Before prostate massage, we can't see prostatic secretion, so there is no point of picking C. EBS, which is this one, EBS, which is after prostate massage, is way higher than VB1 and VB2. Normally, EBS is very low. But if we have chronic prostatitis or inflammation and stuff, we will have high EBS, which is way higher than VB1 and VB2, which is the sign of having chronic prostatitis. Well, someone will ask me, طب didn't you just say in acute prostatitis we can't do DRE, which is similar to this? That's in acute, because acute prostatitis is very painful. But chronic prostatitis is not painful at all. It's just mild inflammation that's going chronically. It's ما في pain. So we can do DRE for them. So it's fine. Which of the following is the agar for bacteriuria? We said in UTI, the first agar that we use is McConkey Cled, because this is very selective to E. coli. So first we need to rule out E. coli, which is the most common cause. So the first one that we use is McConkey Cled agar. Easy. I think we finished micro. Okay. Clear micro. We finished half of the file. So يعني على السريع.
Yes, clear.
Okay, now we go to patho. Which of the following show calcium oxalate stone? We said oxalate, it's X, so it's the one that has X in it. See here, it's a square with an X, calcium oxalate. What's the diagnosis? This one. We said if we have a kidney full of cysts that we can't see أصلا a kidney, I can't tell this is a kidney, and it has cartilage, that's definitely what's called multicystic renal dysplasia. In autosomal dominant, we will have cystic kidney that we can still tell that it's a kidney, and cystic liver. Okay? In autosomal recessive, we will have only inner cysts. So there are no cysts on the outside. هون ما شاء الله multiple cysts on the outside. And cartilage, multicystic renal dysplasia, definitely. History of fatigue, unintentional weight loss, hemoptysis, and shortness of breath. There are lung issues, okay, because he has hemoptysis, and the urinalysis show hematuria. So we said if someone has hematuria and hemoptysis, then that's anti-GBM. Sorry, not anti-GBM, good pasture syndrome. Good pasture syndrome is the one that only has hematuria and hemoptysis, and its light microscopy is crescent shape, because good pasture is rapid progressive glomerulonephritis, the one that causes crescent shape. So it's definitely this one. Only they are saying that it might be Wegener. It might be also Wegener, but Wegener is crescent shape too, so it's the same answer. It's most likely good pasture anyway. But it's the same answer anyway. What's the diagnosis? We said this is the look of renal cell carcinoma, which is very white cells because they have high lipid content. So it's renal cell carcinoma. Diabetic patients who have a kidney issue. We said diabetes, 2 stages. First stage, membrane thickening. Second stage, KW bodies. Here we have membrane thickening, we choose it, and that's it. But what's this? This is normal. يعني إما minimal change disease أو normal glomeruli. Here we have blue, and blue is for fibrosis, most likely, أو حتى amyloidosis sometimes. So it's not related to diabetes. So this is not related. A patient presented with kidney disease that doesn't respond to corticosteroids well. This is a very tough question, by the way. And even I don't know what's the answer that they want. So let's go through it. Patient with kidney disease doesn't respond to corticosteroid. We said the one that really doesn't respond to corticosteroids is focal segmental glomerulosclerosis. Okay. The urinalysis showed proteinuria and hematuria. So this is nephrotic because it's hematuria. And this one is nephrotic. So the question is dumb, صراحة. And the patient is non-user of NSAIDs. NSAID use is correlated with focal segmental and membranous nephropathy, which are nephrotic. So it doesn't match the hematuria here. What is the diagnosis? So let's look at the picture. This one is membranous nephropathy because it has يعني thickened membrane. High is PSGN. And this one is focal segmental glomerulosclerosis. So the patient has nephritic. If I would just go with nephritic, I would choose PSGN, but it doesn't respond to corticosteroids, NSAIDs, and stuff. So it's not PSGN. He is referring to a nephrotic syndrome. So probably this is a typo. By the way, it's not the lab head mistake. It's the 9th batch mistake. They put hematuria. I don't think the patient had hematuria. So I think it's nephrotic syndrome. طيب يلا, nephrotic syndrome doesn't respond to corticosteroids. It's most likely FGS. But here they put membranous because also membranous is related to NSAIDs, but it does respond to corticosteroids. But the head told me, and you guys didn't study FGS that deeply. يعني all the information أصلا I mentioned about FGS not responding to steroids وهيك, you guys didn't cover in lecture. So you shouldn't know أصلا this, and you should put membranous. So I don't know what's the correct answer. The real correct answer is definitely this one. But what is the actual answer in their correct key? I don't know. I don't know what you guys should put. I think the question would be more clear. Because if it's bad like this, فيه hematuria, proteinuria, and whatever, I would put this one. خلاص مع الباتش. And then you guys appeal it. But if it didn't have hematuria and the question is written in a better way, I would put FGS صراحة. But in this formula, formulating يعني هيك, I would put membranous, this one. If it's better, يعني written better, ما له hematuria, ما له أي شيء, خلاص FGS is the definite answer. إن شاء الله ما حيجي. This is ninth batch, never come أصلا again. I don't think أصلا it came in that way. طيب, patient with hemoptysis and hematuria. We said hemoptysis and hematuria, good pasture. Good pasture is linear, so it's definitely C. Patient with hematuria. His past medical history showed respiratory infection 2 weeks ago. Hematuria يعني nephritic. Respiratory 2 weeks ago يعني PSGN. PSGN is the one that is hypercellular. Hypercellular, sorry. It's not hypercellular at all. Hypercellular, so it's C. By the way, PSGN causes this rapid, يعني this crescent shaped, but you don't choose it unless this is not here. If this one is not here, you can choose this one because it's also referred to PSGN in later stages, اللي هو crescent formation. But if you have PSGN, خلاص اختار hypercellular. We will now have multiple questions about this. Please choose the hypercellular one وخلاص. Which of the following is a case of IgA nephropathy? هذا the same thing I said. IgA nephropathy, we took the case اللي هو زي هيك. يعني من جوا بيكون الميزانجيوم is very pink. Okay? But it wasn't a choice. But the crescent shape was a choice. And IgA nephropathy caused the crescent shape. So you can choose it. So this is very old. I think the question is wrong. I bet there was the mesangium thingy يعني. Which of the following correspond with morphology of autosomal dominant polycystic kidney disease? We said autosomal dominant is a kidney full of cysts. Okay? That you can still tell that it's a kidney, which is this one. Okay? You can still tell it's a kidney. ما في cartilage حتى. FGS, which one? It's A, because it's focal and segmental, يعني only part of it, so it's A. Young girl with recent upper respiratory infection, hematuria. Which of the following histologic picture? So it's recent upper respiratory, so it's not 2 weeks, so it's not PSGN, it's IgA nephropathy. So it's like, which of the following is IgA nephropathy? Oh my God, what a bad question, صراحة. It's not recent, it should be 2 weeks. So you will choose this because if there is IgA nephropathy in the choices, you will definitely choose IgA nephropathy, اللي هو البينك material ومدري شو. But here we don't have it. We only have the PSGN one, so you may choose this one because يعني recent should refer to IgA nephropathy, but since it doesn't say يعني we don't have IgA nephropathy in the choices, you can choose PSGN اللي هي hypercellular. Patient had proteinuria, approximately 50% were sclerosed. It's definitely FGS, خلاص we know at this point. Hematuria, proteinuria, hypertension, so it's nephritic. And here we have nephritic, okay? And this one is PSGN. But he didn't say that he has infection. And he said that he have almost renal failure. في high PUN and creatinine. So here, since he didn't mention infection, you can't choose PSGN. You will choose rapid crescent thingy. يعني الرابid sclerosing. Why? Because it's the one that caused renal failure. So high PUN and creatinine also it's appear in PSGN, but it's mainly referring to renal failure. And PSGN, you only choose it if there is 2 weeks infection thingy. So you will only choose rapid sclerosing one, which is crescent formation. I hope this one is clear. 37-year-old female, recurrent urinary tract infection, urinary calculi. So someone have stone, have infection, treated for this condition. They have calculi, multiple cystic dilation in his kidney. He's diagnosed with medullary sponge kidney disease. Which one is medullary sponge? Is this one, which is cyst in the medulla that looked like a sponge. Bas. This is simple renal cyst. This medullary, not medullary, it's called multicystic dysplasia. And this one is autosomal recessive kidney disease because we have inner cysts only, even in the cortex, but it's inner. But this one is the medullary sponge kidney. Which of the following show multicystic renal dysplasia? We have multiple cysts that we can't tell أصلا if this kidney, and we have cartilage here. خلاص, it's obvious. The biopsy of the kidney present with the severe non-selective proteinuria, hematuria. No hematuria, so it's nephrotic. Choose the appropriate diagnosis. So it's like, which of the following is nephrotic, صح? The kidney below patient, previous history, AB titer, not raised. Choose the appropriate. So this one is membranous. This one is diabetic. This one is IgA. So it should be this one. I read the explanation that the lab committee wrote that it should be FGS. But خلاص, there is no FGS in the choices. You need to choose the nephrotic one. The only nephrotic one أصلا without يعني this one is diabetes, which is nephrotic. The patient doesn't have diabetes. You won't choose it. This one is IgA. You won't choose it. You will choose membranous, which is nephrotic. So yeah, if there is FGS is here, okay, you can choose it. But the main one is definitely membranous. يعني. Nephrotic syndrome may cause due to mesangial proliferation. We said IgA nephropathy, which is Berger disease, is due to mesangial proliferation. So it's this one. You see here mesangial proliferation. So as I said, if you have IgA nephropathy and you have this picture, choose it. If there is no this, this picture is not here, you can choose the crescent shaped one. If he said recent infection and this picture is there, choose it. If it's not, treat it as PSGN and choose the PSGN one. Okay, so the answer for this one is Berger disease, which is IgA nephropathy, as we said, IgA. Identify the lesion. This is the KW lesion for diabetes. That's it. Identify the tumor. Here we have the fried egg appearance, multinucleated giant cells. So this is seminoma. This picture should be memorized, by the way. خلاص يعني هي دائما this every year they ask this one as seminoma وخلاص. طيب, the image reveals duplication of ureter. As you see here, we have two ureters on one side. What does it cause? We said in the lecture, two ureters is recurrent UTI and hydronephrosis. ليش? Because these ureters are very weak, very thin, not like the original ureter. So there will be obstruction all the time. So there will be hydronephrosis. And since the urine is always there, it will be causing recurrent UTI. Okay, radiology. Easy stuff. You will just say this, and that. Which of the following epithematous polynephritis? We said epithematous polynephritis is the one that has air and striation. So this one, that one has air. So this epithematous polynephritis. This one is the other one, the xanthogrammatus, whatever, the beer paw sign. So you can't choose it. This one is only striation, so it's pyelonephritis. You won't choose it. Which of the following represent transitional cell carcinoma? We said transitional cell carcinoma is the one that have like pelvis carcinoma. So it will cause the pelvis to be enlarged and obstructed. So it's definitely this one. This one is stone, so you will not choose it. This is hydronephrosis, yes, but it's due to obstruction because it's very thin. You can't choose it. Transitional cell carcinoma causes obstruction due to enlargement of the renal pelvis because it has a mass in it. And this one is renal parenchymal tumor. Like the kidney itself is the one that is enlarged, like renal cell carcinoma or whatever. So it's definitely B. Someone have left loin pain. Which of the following images show an abscess in the kidney? And this one, the abscess is like kidney, and there is an abscess in it, and it's very hyperdense, يعني black وهيك. Black وgray, يعني like this, definitely like this. Okay, this one is renal cell carcinoma, I guess, أصلا. Which of the following autosomal dominant polycystic kidney disease? We said autosomal dominant polycystic kidney disease is multiple cysts in the kidneys, both sides, and the liver. And this one, the only one that has that. Which of the following associated with tuberous sclerosis? We said tuberous sclerosis causes seizure, mental retardation, epilepsy, and angiomyolipoma, which is blood vessels, lipids, and muscles. So mass full of everything. Which of the following has a mass full of everything? It's this one. This one is the emphysematous pyelonephritis. This one is infarction. We explained it. طيب, which of the following is caused by schistosoma? Schistosoma causes bladder calcification. So it's this one. Which of the following show renal stone? We said renal stone is a stone that looks white and behind it is shadowing. So this one is a stone that is white and behind it is shadowing. So easy. You may ask why it's not this one. This is not a kidney. This is the bladder. Okay. Bladder stones are very big. Okay, most of the time. So link to this stone. It's very, very big. So no, you will not choose this one. It's the gallbladder. This is the kidney. A very small stone, shiny, and behind it there is shadowing. Just choose this picture. It always come. Patient with flank pain, nausea, vomiting, so it's like pyelonephritis, I guess. Diagnosed with pyelonephritis, yes. Which CT scan? It's the one that has striations. So look here, it's striations. Which of the following is cross-fused kidney? We said cross-fused kidney are two kidneys at the same times that are at the same side that are fused. So it's this one. It's not this one. This is horseshoe kidney, which is fusion of the inferior lobe. If two kidneys are fused at the same side, that's cross-fused kidney. Which of these is Wilms tumor? We said Wilms tumor is a very big tumor of the kidney that causes it to be massively large and even larger than a liver. So this one, definitely. 40-year-old diabetic has UTI, also present with flank pain, pyelonephritis. Which one is associated with the diagnosis? And we said that this one is, we already explained it in the lecture. Pyelonephritis, striation and stuff. He also have stones that also predispose him to pyelonephritis. And you see here, there are striations. اللي هو أبيض رمادي أبيض. And there's also stones here and there which predispose him to pyelonephritis or flank pain وهيك. So this is definitely the lecture. It's in the diagnosis. Pyelonephritis we also have renal stones. Image picture here, what's great, it's this. So as you can see, it passed through the cortex, reached the medulla, and even affected the renal artery. This is grade 4. Okay? If it's completely shattered, destroyed kidney, that's grade 5. Okay? But here it's يعني reached the arteries وهيك, but still the vein is fine, upper part is fine. It's not completely destroyed, so it's grade 4. This is horseshoe kidney. Inferior lobe of both kidneys اندمجوا and they fused and they are ascending and blocked by inferior mesenteric artery. To ask you which of the following is the most common complication, it's the stone, which is canaliculi. Okay. What is this? We said this is hydronephrosis, enlargement of the renal pelvis وهيك. So this is hydronephrosis. Describe what you see here. We have one ureter here, but here we have two ureters. So this is double ureter. And if to ask you what is the complication, recurrent UTI and hydronephrosis. And that's it. We finished. This is the feedback QR code. Please fill it. And if you want me to change anything, please fill it not just for the solving question. I know I was just passing by them quickly because I already explained them in the lecture. I don't want to spend more time. Please fill it for the lectures and the questions. If you want me to change anything in the slides, in any explanation. So if I took any OSPE sessions in the futures, I edit it. So please fill it. And like if you liked it, please say that you liked it. So I know that what I'm doing is something you guys are benefiting from. Any questions?
Amazing session. بيض الله وجهك. Thank you so much.
Thank you. خلاص يلا. Thank you guys. These are my information. If you have any question, anytime, please reach out. يلا, see ya.